So in supine position with a Harding's approach. The acetabulum shed on both the sides size was 50. The ceramic head of 32 was used, and a stem of 9 on right and 10 on left side was used. So these are the immediate post of X-ray. I hope
which was done first?
The left side was done.
So the left side was done first, and you had a much better inclination. Any reason for that?
So it was all we do in supine. It was all whatever looked the best in supine position, and of course we do have a possibility to check on Sinha, and that was the best inclination on either side. So that is what. Yes, I mean
take home message from these guys will you actually what about your version? Normally I'm a posterior surgeon, so I do lateral position and posterior approach. So normally I slightly increase my anti-version. In routine cases with spine, it's not a problem. But in these cases when spine is fixed and lordosis is not that much, then probably you will be very careful in antiverting these cups quite a lot. Okay, because if you antivert them, then there will be a chance when the patient is lying down and turning, it may dislocate anterior. So very careful with your version. You're with a posterior hip surgeon. I don't know about the engineers, how they look into these things because it's completely different. Because normally I will increase my antiversion. Normally in these cases, I'll be very careful not to increase my version. Okay, I'll be really very careful. So there's a high chance of anterior dislocation, not while sitting, while you are either standing from sitting or while you're lying down on the bed and turning forward. That is where you have to keep it in mind in these particular.
So I don't know how many of us have seen the large head dislocating, number one. Number two, in hands-on, you are blessed with sickness. So a lot of sickness remains and kind of makes you forgiving on, had it been a rheumatoid hip or something else, probably it would have been far more amenable to dislocation. I don't know how many of us have seen dislocation in large head in hand-on patient.
I think soft tissue release is a very if these cases are 20-25 infection deformity, then adaptive anatomy and the releases of the gluteus and all, these really comes a lot. And using a lot as Sharan said, that reduces the dislocation.
So now if you look at the way a patient is sitting, his left hip, which was done with a more horizontal cup placement, has a much better, it looks more comfortable hip than the right hip at this point of time.
These were the X-rays done just 2 days back, and this is the final follow-up at 2 years now. As such, the patient is quite happy, no complaints at all. Of course, he's overexcited and kind of spots also when he comes to us, which should not be done actually. And this is the final result. I end my case there. Thank you.
So, was it a ceramic head?
Yes.
That's a very forgiving situation.
Very informative, Dr. Jaswinder. Thank you so much. One particular thing which we wanted out was DMARDs. If anybody prefers to give DMARDs for quite some time before taking up these cases, because I think when they definitely help in improving some degree of stiffness in these cases, and especially by
other than anti-TNF alpha agents, you don't really need to stop any DMARDs.
If patient hasn't taken any medication, so you start and wait.
Wait for some time and
so I'll come to this question now. In hands-on, it is a completely different spectrum altogether. DMRDs don't work. What works is, as Dr. Rastogi said, anti-TNF alpha or etanercept is a drug of choice now. It's not even anti-thing. So if your patient is in an inflammatory phase, that has got a high CRP, has got an active disease, in that case, these anti-TNF alphas would actually help to reduce the stiffness because the pain is controlled by anti-TNF alpha. But if the disease is burnt out, disease has no CRP levels, they are not high for past 6 months or 3 months, and you don't have very inflammatory, although the pain has component has gone down and stiffness component is more, then I don't think any DMRDs or anti-TNF alpha will have a role in controlling your post-operative or operative risk. So that is an important thing which we need to understand. In hands-on, it's a different pathology. It is not the regular inflammation which is there. My take on your question is this. So not all the patients would be.
And anything on fractures? I have encountered a couple of fractures in hands-on, especially during these preventions.
Rightly highlighted the role of anti-inflammatory, DMARD drugs. And as he has rightly said, cases which are already burned up, you need not wait for these drugs to act. But there are situations when the patients are on the younger side, there will be a plus or minus. Can he improve? And I will tell you a short story. A patient came from Chhattisgarh, telling that everybody has to prescribe me a joint replacement. A similar patient had come to you, bilateral hip involvement, and you have given it an set and other drugs. And the patient is squatting, sitting cross-legged. And so he brought his prescription also, his X-rays also, and said, "Oh, you please write it." So there are times, now I have a series of 6-7 cases, not many, but resolve or use of these DMRDs and which are infliximab or etanercept. That's based on also the acute inflammatory component and the radiological changes. Once you have a huge hit, nothing is going to do, no drug is going to help at that stage.
About fractures as well, because I have encountered quite a few.
So the second prevent one is one that you prevent before dislocation. So you have to take out all the osteophytes, although it's not a procedure yet. But if it's a procedure, you have to take out all the osteophytes, be very gentle while dislocating. Okay, all the osteophytes, take a glove to cut it all around and go anterior, because there are times when you take it out posteriorly from posterior, and you are not done immediate, but then you're going to dislocate fracture all the anterior osteophytes along with the anterior column. It will be hard for you to see. So that is one. Second, there's no harm in cutting in situ.
Yes,
There's no
yes.
harm in cutting in situ and then take the head out. Or yes. So that is there are two things, because these are pilotic changes. It's not only internal most of the time, but then still it is very, very difficult to dislocate. So you have to be very, very gentle. They are very fragile. Many of them.
So thank you so much. Going to call upon the next speaker, Vijay, Dr. Sharan is going to speak on THR in pain. Yes.
Good afternoon, everyone. First, I would like to congratulate and thanks John sir for starting this fantastic course on both dedicated to THR, and I would also like to congratulate the whole team for organizing this seminar on THR. So first, I will be presenting few cases. May I ask one question, sir, regarding last case. Sir, in cases of ankylosed hip, due to ankylosing spondylitis, bilateral cases, and if pelvic tilt is there and the spine is not fixed, and let's suppose one is at higher side and foot is leg is adducted and another side is abducted, isn't it recommended to increase the inclination on the elevated side, that is adducted side, and decrease the inclination on abducted side, so that in time when hip settles and that abduction corrects and that pelvic tilt corrects, then it automatically comes to normal side. So reduce inclination on the side where it's abducted and increase inclination on the side on which it's adducted.
No, see, the inclination is, it is related to horizontal tal. This is absolutely not related to pelvic tilt. So if you are going to do that, it is going to create a bigger problem. That's what I understand. We are getting away, I'm saying repeatedly, and because of these mistakes, only large heads have come, and now the newer heads have come, which are dual mobility heads. So you are going to get away with almost anything you do now, and it becomes so forgiving. But I think the concept of changing pelvis is making it vertical while trying to adjust to the pelvic tilt is a notion we should not get.
I read it in two of the article quoting it that you can change the inclination to correct the.
You stick to the horizontal and tal, and you automatically will get, even if the pelvic tilt in future corrects, the correct inclination. Okay. So if anybody wants to share.
No, I said where fixed spinal deformity is not there.
Regarding this question, what we are getting connected over the time within 3 to 6 weeks or a month, that is your muscular power of the state physicality. So you want to address the issue of soft tissue with bone correction. That is cardinal law of orthopedics. You are not going to correct soft tissue with bony cuts. That is true for TKR and also for hip. You are trying to compensate the muscle loss which we have developed over the years or months due to stiffness of the hip. So as you release the hip, you maintain a native joint. With the passing time, you will develop good muscle power, and that will lead him for a perfect hip mobility.
Thank you.
You need not to change.
Please start. Okay.
So this was a case of 69-year-old female, and she had fixation of intertrochanteric fracture 9 months back. Initially, she was able to walk with the help of walker, but since last 3 months, she was not able to walk. In X-ray, there was a cutout of the screw, and fracture was not united. Inflammatory markers were within normal limit, and hip aspect was culture negative. So, looking at her age and bone condition, we decided to go for total hip replacement. So, this one is immediate post of X-ray. We went for uncemented total hip using long stem bypassing the stress riser of the previous stool. During cross, there were slight states to be used as wire to reduce the to hold this fracture. Next one is 1 year follow-up X-ray. This is the 6 year follow-up X-ray. Actually, we asked for X-ray. This is yesterday only, and here is the video. We have taken this video yesterday. So I would like to present one more case of, then we will go for question answer. So next case, 62-year female, history of fall with intertrochanteric fracture, fixation with cephalomedullary 6 months back. Since last 1 month, she is not able to walk. There was non-union of intertrochanteric region along with broken screws. Osteoarthritic changes were also evident in the hip, and inflammatory markers were within normal limit. Hip strain was also culture negative. So in this case again, we missed immediate post of X-ray. This is 1 year follow of X-ray. Again, long cemented stem was used, and uncemented cup was used. And this one is 4 years follow up X-ray. After 4 years, she was lost to follow up. So these two cases of failed intertrochanteric.
I think that we could have preserved this. So how do you say this is a only broken implant is there? But I think the bone stock is good, the medial.
Actually, sir, both the screws were broken. And we find it that we may face removal of the big screw. We are going to further dismantle the bony architecture, and it must have been very difficult to get the either the DHS or either of osteotomy. Everywhere it must be coming on the way. And she was of 22 years of age. So looking at her age, and again, osteoarthritic changes were also evident in her hip. So looking on all these factors, we decided to go for this. Next is, so, sir.
The first case, you leave the trochanter as such. You see, there is no wiring for that. For greater trochanter, you left that person as such.
So do you think it should be done something else also along with that?
Maybe wiring.
Yeah.
But on table after that cutting the head, it looked like it's glued and it's enmasked. In most of it, you can see that it's enmasked with the stem. It was not free. That's why we went for.
Yeah, but it's always better to do the trochanteric wiring. Hardly it's time to tell you that something. And itself in your character concern.
I think I would go one step further. Can you see the second case also present? Yeah, so he did do trochanteric wiring. But see what happens after some time. Next. So you see that there is trochanteric escape and broken wire after that also. I've stopped using wires now. One thing, of course, what he said is, I think absolutely right. You must take care of trochanter, get it down that place. Now I've started using a small hook plate, get it down, get your trochanter down properly, and fix it nicely. Or use a cable system and a trochanteric claw. Don't use simply wires; they will always break down, and you will have continuous escape. In your first case, the trochanter is now nearly abutting the acetabulum. That is the reason why this patient is not having proper gain.
So next case, this was an interesting case. 57-year-old male. He was having pain around left hip since last 6 months, and able to bear weight over his left hip. X-ray showed lytic lesion involving whole of the greater trochanter, complete neck, going up till head, and also there was pathological fracture, and patient was not able to bear weight. Histopathologically, it came out to be a case of aggressive type of GCT with mitotic figure. I missed those MRI picture. So, what to do in this case? Sir. So that is what we offer to the patient, to go for femoral total femoral replacement, or to go total proximal replacement, or to go to a center where he can have allograft, where they can reconstruct with the help of allograft. It's very commonly we were doing allograft replacement in these kind of cases. In fact, I have encountered 2 or 3 cases. I have just assisted in those cases. But he was actually from where he was also group was, he was not having family support and he was not having funds. So
First, I'll ask for an MRI. Do you have an MRI?
yeah, sir, I had an MRI, but somehow lost. At present, we are not having MRI, but both of them, his head was involved, and it was extending to somehow proximal part of metaphyseal region of the finger.
It is going below the lesser trochanter. This whole the lesion is going below in marrow area, below the lesser trochanter.
Sir,
Then you don't have a choice with conventional implants. Then you don't have a choice. If we do it as a part of our compulsion that we don't have infrastructure or patient is not able to afford, that is even then I think it's a very difficult situation for patients in the long run. You won't have the survivorship.
sir. So what we did in this case, we excised end block
proximal femur in block, and uncemented porous coated cup was used, and reef stem was used with locking screw, and abductor was attached over healthy bond suture. This is immediate post of X-ray.
This is, now we cannot get away saying that it is cheaper than, there are different systems available, modular total femoral systems, which are equally less expensive, same cost. Yeah. Something which is, if you can use the reef stem, you will definitely get in the same cost, the proximal femoral system.
So I would like to show my follow-up X-ray. So this is 3 months follow-up in which we see that stem was osteointegrating well. So then we allowed patient to walk with the help of walker with partial weight bearing. Second X-ray is 1 year follow-up, and third one is 3-year follow-up. This is patient at 3-year follow-up. He is able to walk. And actually at that time he came for his pain in his contralateral hip. He actually had developed some osteoarthritic changes in his contralateral hip. He was even able to move over the table unassisted. He was able to sit comfortably. So yesterday I just called him and he sent me recent video. So this video is of yesterday, 4-year follow-up. He also sent actually X-ray, but he just took it, taking it in hand, so it was not so good. So this is 4-year follow-up X-ray of that patient.
Maybe we follow it up for more time, but this is a very good result coming from a very innovative way of usage of, obviously we've done a very but we need to understand again what is working here is how long did you ask the patient not to walk after the surgery?
So for 3 months, initial
3 months patient did not bear weight.
He was walking without just total bearing with help of walk.
So what has actually saved that here is again the large head. You see, this whole the stability part initially was taken care of, and I don't know whether you would recommend it as a treatment of choice in a patient who is coming on a regular basis.
It's the interesting thing which we can see in 3-year follow-up X-ray. Heterotopic bone formation around.
But you must also understand that the bone formation there which is happening, a lot of tumor spillage can happen in that area. So we are looking at trying to sort of get away with some kind of wishful luck. You did not even imagine that this is going to happen.
That's the point which is worth noting. So you have bone formation, which is perfect of bone formation. That means the rejection has been perfect. And the section is more important. Then how do you explain the formation of this bone?
It has to be osteogenic.
It has to come from remnant of some period.
Some osteogenic cells must be there. They can be disease cells.
So they can be disease cells, and it is in fact actually a wrong thing to have this kind of new bone, because then you've got a 4-year follow-up. GCP recurs maximally in the first 2.5 years, 3 years. So that's okay. You have basically passed that time and still not recurring very nice, very good.
Plus, it's not such an exposure.
So I think that is good. That is why you've got a fantastic result. But it's generally not a good thing to see newborn formation when you have done a proper extra periosteal in block reduction for it. It will not be seen.
Actually, in initial 3 months only we have seen that initiation.
Patient up with some MRI or something so that you can detect recurrence better.
We had actually done MRI at 2 years and it was normal.
I think you basically escaped for that.
So this is the histologically proven cancer tumor.
Yes, sir.
So you still have, it's not really a malignant lesion. That's why you can get away with this. Otherwise, the excision has to include the compartment. Okay, so that's a different situation. This is not a malignant lesion. It's actually a benign lesion where local have had other options as well to treat it.
Thanks. Thank you, Dr. Krishna. One more thing which I like to raise is these conditions of failed DSN, which is very common in our scenario, is the ability to calculate the height of the stem and the offset for long-term results. Because many a times the geometry is not like what you did in a native right? Your idea is one, if it is also any particular tips and tricks has to calculate at what height should I be doing this thing. So that my real length and my
and for fracture. It's also not helping to the cost. Probably you have to maintain a balance between the length because you have to free your posterior approach again. You see how much lengthening or tightening you are making. Okay, because of the contraction, release a bit of this maximus as well, and probably that will and then standard leg length measurement while you are operating another patient will help. But if you are falling short by a centimeter or less than that, it's fine. You can't
level of the head. First of all, I'd like to partly all the way from and this plastic. I don't have one. So here I'm presenting a case. He's a 35 years who is complaining of pain right hip for more than 2 years. And he has a limp since long time. And on examination, he has limb shortening and painful rotation. So I'm straight away going to the X-ray. So this is the pre-operative X-ray. So the right hip is plastic. Okay. There's no further guess. Is a clear that it's plastic. So I was quite afraid to what to do before taking into the case. So we didn't have homework. Like, so whenever you see these sort of cases, you need to clarify because there's a universal mode of communication and language to prognosticate as well as decision making. We know the most followed on the role classification where you measure the amount of height of the head from the normal position in relation to the length of the head or the total telemetry. So calculating those, our case was falling in row 3. So now what problems are we anticipating in these sort of cases? Quantity. So we have made a list of problems which I will anticipate on table. One is on the establishment side, finding out where exactly the 12 step. And the second thing is, I know even if I find out it will be very shallow establishment. So how to place my from as normal or possible. And the second thing is the establishment is vertically elongated, like the superior diameter is more than the anteroposterior diameter. In other way, it is superior wall is grossly deficient. So on the femoral side, what we anticipated is one is he will be having increased femoral neck anteversion. And the most important thing is will be very small femur. This plastic keeps out small narrow. So going back to the X-ray again, so I would like to ask the panel what have been planned and what could be done. So as you said, I'm also a posterior surgeon and we plan an unsymmetric organ condition.
patient is having a Okay, so what's the age of the patient? 35. So you have to understand that patient will have to get to a lot of problems. And so what do you want? You want to put the cup, bring the head down and bring the cup in the native place, or you want to leave the cup up? What is the idea?
Idea is always try to bring it as also near to the period drop, but in this plastic there is
So I think that it is discussing. I don't normally go for any theater. Okay, to find a good book. Okay, although there are contradictory views upon different surgeons, then somebody will say break the hip down, but it's not easier said than done. So wherever there's a good bone stock, of course, it's not very hard. The problem is with the shorten and how we to fix it. So and the version. Because these patients are not unstable. They are walking, they're just coming to you. Maybe the patient that I see in that right the marriage time 25 manage the problem. And then they come to us. Okay, and of course we have our share of responsibility for these patients. And we have modularity of burden. That is very, very important. So modularity of burden is not very important. Prepare for revision. Yeah. Go up on it and explaining the patient how much gate balance you're going to. The other side is involved. Spine is involved. That is also important. You may do a very good job of it. The spine is for 35 years. Spine is also. You're not going to do anything. So you have to be open and you have to explain everything to the patient. And share this problems are always.
It was around 3 to 4 centimeters. Less than 4 centimeters. Less than 4 centimeters.
So obviously, not much problem with the cardiac.
Yeah.
You can get it down.
As such, most of the dysplastic
Times in detection, retraction, and in the case of these are the surgeries that you don't do it routinely. If staff are not ready, as you said, you have experienced only 2 cases. So in the case of retracting, getting it down, time is against you. These are the problems that happen during surgery, not only because of that.
So what we did was and what to do was on the establishment side, we need to identify the teardrop or the talent so that we know where exactly the orbital establishment or at least we're trying to bring it down there. And don't hesitate to even have a couple of monoscopic shots if wanted. And most important thing is you need to do an aggressive medial healing. There is no harm in going a bit protrusive in these sort of things because you want adequate coverage of the cups. And regarding the
superior you want a good column fit. Yeah, you want a good column fit, so even you go be like right here.
Yeah, and then regarding the superior wall deficiency, what we thought the easiest way is once you top of the head, you take a chunk of head, fix it provisionally with a couple of KYs.
Okay, so
and read
that it's very vertical. As soon as you want to pass, will come into the way of the system that are going to put it. That is why theoretically speaking, keeping an augment is always the
and on the femoral side, as I told you, you should always have the CDH stems in your armamentarium. And once you do a low net cut, so antiversion will really overcome. Yeah, yes. And you need to use use and as I told, you should be ready to do a subtrochanteric hysterrectomy if you don't take it. That way, you will get away with this patient by doing a middleization of the cup, patelloplasty, and put a middle bone gap. And during the femoral head autograft closure, fixed with couple of screws. And the stem you will able to get away with the 1 6. This is a more than 1 year problem. Thank you.
So you have to understand that abductors not by the time Amit is loading up, you've got it. So abductors also are a problem. So you can't bring you can't bring them down. So you can use 5 or 6 Just last year, or we have started the fever variant. So coming to a bit of free, what are the options possible? And you can erase the latest point, so we keep on erasing. That's what yeah. What you can never try upon shortening the payment, yes. And you can use those graphs, you can just delete it and have it as leaving it. That's the best convention of proton mass for surgery. And do the development of your so that's what we were mentally prepared for that one, but we are able to land up a that high, and we are able to bring it down by 3 centimeters, so we are able to stabilize the thing. That's why we did do that proton process. Like my hip center is definitely 1 centimeter high above.
It doesn't really matter.
It doesn't matter.
Up to 1.5 centimeters of this raised hip center, not really matter. I think we did a fairly good job actually there. And remember that subprofessional constructions don't release your effort. That will still be there. So the subprofessional construction should be done only if you plan, if you really need to bring it down, and specifically for Pro 4, not for Pro 3. Pro 3, Pro 2.
Now I would like to follow on Dr. Aditya, independent board chair and
this patient was 18 years. Almost after 1 year. After surgery, it was done somewhere else. After 1 month of that, with this X-ray, along with there was opening at the site of surgical scar, and there was sciatic nerve also. This was the clinical picture, and there was intermittent bleeding all the time for last 1 year. And in between, he was and this was the CT of this patient. His posterior column fracture with the posterior wall, and head was still almost out, with almost around 30–40% of the head was resolved. So this patient was planned for debridement first because, and there was infection also. So patient was planned for debridement first, and this was when we opened the complete wound. After extending the incision, this much of clot was coming from that wound. So this much of the clot was there. And this is 1 month after fixation of the problem. That was done within a week after fracture. That was done outside. And after 1 month, they came to us with this related young.
Why did you not do a pre-operative angiography?
Yeah, CTAJ was that says there was injury to the superior gluteal artery. Yeah, okay, good. CTAJ was that this picture was that in this.
We also did I think we got an internal.
Yeah, next. So this was the wound, and this was the femoral head, almost 30–40% was resolved. And this was the sciatic nerve scarring was there. Picture is not very good. And we also did the neurolysis of that sciatic nerve. This patient was having sciatic nerve. So this was a diagnosed case of superior gluteal artery post-operatively, and through which bleeding was intermittent here. So Dr. Sujit, this superior gluteal artery was difficult to find from this place. So what will you do next?
Actually, in our center, we normally do the angioembolization. Basically, we refer to the radiographic system, they do the angioembolization.
Okay, perfect. So this was
See, you have found it later on.
yeah, it's very difficult to explain.
So actually, we have an engine group, but then if it is found before surgery, then of course you can do that all those things. But during surgery, if you found that it is not is that much, probably just back and try and locate. Otherwise, put some hemosil and something like that, so that you will get it. Otherwise, getting.
How would that work in the presence of active infection?
Yeah, basically it is your pre-operative diagnosis. You have done the CT angio, and if you suspect some aneurysm or if there is some leakage of your diet, then probably at that time you can say the radiology people to do the angioembolization. It is a pre-operative treatment, not intraoperative. You cannot do it during the surgery. And
What I wanted to know is when you know there's an infection
yeah,
with a long-standing situation where bleeding has been going on, will it work at that situation or not? That's what I want.
well, angioembolization is definitely okay.
So, this superior gluteal artery was untraceable. So that
I think if already superior one month old refractory superior gluteal artery is bleeding, I think the only way is packet and go anti. Yeah, and that's
Probably you can go into fetch that anti one will get that much of infection. But up to my end, I could not have done anything. Packet, close it, wash it.
So initially,
To end this with next couple
so
of.
initial call was already given to the cardiothoracic surgeon. He came, he did laparoscopy, LGRE, and ligation of the internal Indian cardiovascular. And this was a implant review was done at the same time with property damage was done. So this was the picture in the post-op period.
Actually, Dr. Arvind, if you see the X-ray, actually, one could guess this particularly in the region to the superior gluteal artery in the pre-operative before the established fracture was treated, because it is exactly at the sciatic notch level. Yeah.
But we have a lot of such type of displays with posterior column fracture, but hardly we find because of fracture there is injury to the superior gluteal artery.
No. I'm not saying that. The fracture
Doesn't try to reduce all that fracture.
Yeah. So it's happened. So it happened if you are not very experienced and you are dealing such type of difficult posterior column fracture. So chances of injury to the superior gluteal artery is. So this is after almost 1.5 months of this development, and ESR CRP was settled down. There was no any sign of active infection was there. So at this stage, what should be done? Whether we should fix the sternum column first, and then in second stage we should go for THR. 18-year male boy, very happy guy, almost 90 kg. So what should be done at this stage? Single stage or two stage?
So I think it's infected for sure. Okay.
No, infection sign has settled on. ESR, CRP, everything is normal.
How many months? Let's say 3 months. Let's say 3 months is gone and patient settled
2 months. 7 weeks. Yeah, almost.
Yeah, but then still posterior wall will be, I think, gone. Posterior wall is gone.
The posterior wall fracture was.
And you have taken out the head as well.
Yeah.
So that
Column fracture.
posterior wall is gone.
This is the.
Yeah. So I think tell you a lot about posterior wall. So definitely.
So we had CT initially that says that
Posterior wall is
you can also trace this posterior wall fracture in there.
So
And posterior column is almost displaced too much.
So I think if the infection is
Settle down. There is no problem with
fix it.
infection.
you have to, we can do single state, but you have to fix the posterior column first. Reconstruct the posterior column. And then if the wall is still deficient, maybe an area graft for the posterior wall. And then you can do it transplant.
So we have option for both single stage fixation with DHR, or you can go with the 2 stage. First fix the column, bring it to down, let it to heal because this was very bulky guy and you do second stage DHR. So we CT stage. This was the CT.
no. But after the removal.
After that, I don't think any further requirement of CT in this case.
probably Dr. Arvind, only one concern is that the wound was open for last 1 month. So it is just a sinus which is exposed. That means your joint or the soft tissues are exposed for almost 1 month.
Yeah.
Probably I will go for 2 stage.
So that's why we opted for the same. Yeah, so we opted for the same, the 2-stage procedure. In the first stage, we fix the posterior column and bring this as much as possible to the normal anatomy. And this was the after fixation. This was the X-ray. So almost reasonably, the posterior column is up to the normal anatomy. And this fixation with the 2 plates and the this upper tibial injection was applied. So as much as we can bring the later compression lower down. So this was the X-ray, and this is after almost this 2 months of this primary fixation. This is the X-ray. So their problem was first exposure. Initially, all the things was done from the posterior approach, and because of multiple surgery, repeated scarring, so this was the exposure problem. Next is the high riding trochanter that we can see, and also because of the sciatic nerve injury, there was adductor insufficiency also. So these common problem was present.
Really, recovery of the sciatic nerve,
No,
the kind of you have
no recovery yet.
I just want to ask, can we plan like at the same sitting when you're creating the posterior column? How about a sweet space in the femoral state?
Yeah, I would have actually.
So that would bring it down because it will maintain it is mid space for the next 2 months. That will gradually coming down, and it will not be.
Yeah. So if you see the X-ray from very beginning, first time a skeletal traction was also given, but tumor was still there. From first X-ray, in the next X-ray it was still there, and even after 2 months of a skeletal, 30 skeletal traction, this was the X-ray with this. So it was very difficult to bring it down that time.
So what was that?
So at this stage, these
So
were.
when you explored the hair and
Yeah.
you moved the implant, what was that?
So you mean to see what was the intra-op thing?
Yeah, what was that?
Which structure was tight?
What was that?
So it was very difficult to just keep it down very smoothly. So all the time this was there.
Because I think that the suggestion is not merit if you are going to go into a hair to disinfect it, basically, debride and disinfect. You go proper debride,
Yeah,
and most of the soft tissue will go off, and you will have some amount of distance. And then try and get your spacer inside.
Yeah.
That will increase the distance, the higher GT distance will increase. You will have at least better this thing, and you will have some amount of length, and it will become easier against stage data.
Yeah, so that may be one of the possibilities that could be done, could have done in this case. So in this case, since there was abductor insufficiency was there, that was the real indication for dual capillary cup.
Yeah.
And because of thigh surgery was done from the posterior approach, this time we choose modified Harding approach in supine position, so that we will have this option of Siam also, so that we can check if everything is in place. And at the same time, because of high trochanter riding was there, so trochanteric osteotomy was done, and the was weak, and this center was being on, and this was almost immediate post-op. You can see the skin stapler is there, how far it is. So this was very bulky guy at the age of 18 years old. So this was the immediate post-op X-ray, and this was after after suture removal. This was the X-ray. So you can see the posterior part is getting almost, it was the healing phase, and this is after this was the same X-ray level, and this is after 3 years of this X-ray. This is 3 years. Getting now still not improved, and this was he came this time for tendon transfer, posterior tendon transfer, but because of some exam issue, he again opted after 6 months. And posterior column we can see this is evolutive stuff. The cement is the dual mobility that was the double towards that line. Sanjeer was
one has to be extremely careful of heterotopic ossification. So did you do anything to prevent that?
only endocapes that were in mind we have. And nowadays we have started some radiotherapy part also in some patients. Those who came with heterotopic ossification around the hip, we do release and we remove all the bone, then we send for this radiotherapy part to the radiotherapy.
Wonderful presentation. Thank you so much. I'd like to thank our chairpersons, and I'd also like to thank our speakers. If anybody in the audience would like to ask some questions to our chairpersons or speakers, you'll be welcome. I think we'll wrap this session. Thank you. Thank you very much.
After concluding, it has been some announcement.
After everybody, thanks for you. We are having an assignment a basic course, in Patna, 17th to 18th of December. We're having very good courses, life surgery, special session on LRS and Kapoor also. Anybody who is interested, please contact me or Mr. Vijay of BO is here for the session. Thank you, thanks a lot.
So meanwhile, may I request Dr. Jasvinder Singh, Dr. Sasikant and Dr. Aditya to please come on the track. And I'll request Rastogi sir to kindly facilitate Dr. Aditya Mutha. Dr. S.S. Jha, sir, kindly come and facilitate the Dr. Jasvinder. Dr. H.N. Vikas sir, kindly facilitate Dr. Sanjeer.
May I request Dr. Bhadani sir to please facilitate Dr. Aditya.
Please, Dr. Kumar, come on the desk. And Dr. Bharat Singh sir, kindly facilitate Dr. Kumar.
थोड़ा आगे
So moving on to the next session, that is basic hit session, and the moderator is Dr. Vijay.
Good afternoon, all of you. Hope you are glad that the case is operating. This is a very interesting. I would like to share Dr. Basiram,
क्या होगा उसका मैं जानते इसको सैंडल बोल रहा है ये टच कर रहा है मेरे में डिस्टर्ब हो रहा है
Dr. Amit Rastogi, sir.
now I would like to call upon the practice in the.
Very good afternoon to one and all. So, very thankful to Dr. Team Forest and the one and all for inviting me to talk with the here. And I will be talking on a more exact way of doing things. That is a direct NTR. So I am on a fellowship trained surgeon and I work at Anup Institute of Orthopedic and the everything. So a more way of doing things with a direct implementation. This is not for I mean, it has been actually when we talk of hip surgery, there are so many approaches that we all are confused. Most of us do hips with one particular approach, and they have a deficiency who have learned a new approach. And obviously, learning a new approach means more time. So what I would like to say, different people have got different approaches, but every approach has got its own pros and cons. Choose an approach on which you are trained, and approach should be held in your feet. And do not be dogmatic. I would be doing only this approach, but that approach. Try to be learning, try to learn these two approaches. So that you for all these, the choice always depends on the patient, the surgeon, because nowadays the patients are more demanding. That is, they ask for small incision, MIS, and they know a whole lot of stuff before they reach. So I would be talking briefly on the history, anatomy, evidence, and lastly about the pros and the cons. So the approach was first described by Aditya way back in 1821. So it's not very new, and it was also Smith Peterson who propagated the direct anterior approach and the modification. However, it was limited in various parts of the world, and later Judith brothers in France popularized it. And in the US, it was popularized by Krishna. Now, Mutha also popularized this, but the most important change, which was a change actually, was to do it on a supine table, normal table, or a dark traction table. So at this point of time, direct anterior approach can be done on a traction table and on a normal table. The principle of approach remains the same if you are using a traction table or not. So let's talk of the anatomy. Believe me, it is very simple. The patient is placed supine in the small standby on the lateral side of the buttock. An incision should be starting 2 centimeters inferior to the ear size and it drops towards the fibular chain. A small incision and the plane is between the sartorius and the PSL. Now here you find the fascia over the sartorius and the lateral femoral cutaneous nerve has to be separated. The most important aspect is that once you identify the gap between this, you need to cut and retract it, and then you reach the rectus femoris muscle, which needs to be erased off, and then you can rotate the leg and feel the head moving, and then you can cut the capsule, and then you have the head exposed. So I will show you a small video because I do direct anterior approach rotate to patients, and I select my patients. I do hip approaches. Almost 3-4 approaches I approach, and if you have a look at this video, just a 2-minute presentation, but you see the patient is supine. So number one is that the patient is supine. As I told you, 2 centimeters in base, and the incision is directed towards the fibular head. Sartorius and the PSL, we take the base, and then we put the Charles clamp. Even not required to put the Charles clamp. And then we rotate the leg and feel the leg. Now here, the rectus femoris, we put the clamp and then erase it, and then we feel the capsule. At this point of time, the capsule can be incised with a pottery. You can see the capsule will be excised, and once this is excised, you are directly on the femoral head.
And I'm not showing the other part of the video. The main play is of the leg. You keep it in a figure of 4 position, and then the stem would be exposed. So once the stem is exposed, then you expose the lesser trochanter, take an incision according to the calculations what you do in the field of planning, do the standard broaching, what we require to do, and then you take it from there. Now, the exposure of the sternum needs is a bit more tricky. Why is it tricky? Because you need a bit of more special detector, and you should have a 360-degree orientation of the sternum. But believe me, it is not tough. The incision is small. There is no, the pain is less, which I will talk to you. And you can see that after closing, this is just a scan view of the X-ray taken. And we close with the plane. The capsule is closed with everyone, and then the incision is not more than 5 centimeters, 4 to 5 centimeters, very small incision. Now, one question which lots of people ask me that which approach do I prefer? So, practically, I do all my partial hip replacement with the anterolateral approach, total hips with posterior approach, and a wee bit of patients I select and I do direct anterior approach, that is dark. So, the second question is, what do I feel the difference? So generally, when we are doing a total replacement, if you're doing a posterior approach, you just adapt, still notice that the hip comes out. When you're doing with anterolateral approach, you still need a hook and then it comes out. But when you're doing a dark, even if you put a hip dislocator and in a clamp, it doesn't come out. So dislocation, even on table with the trial processes, is tough. So in real life, it is good because dislocation rates are less. The patient, we have to choose the patient for this thing. As I told you, we need special detectors. And it is very important that we learn all these new approaches, we train in new approaches, understand and take it from there. Now let's talk about evidence because yes, all the pros and cons and the evidence. So they say, the literature says that yes, there is less soft tissue damage, faster and easy recovery, lower dislocation rate. But do you have data for these claims? So we see in various literature that the CRP and CPK, MB, etc. are more higher in posterior approach and more so higher in anterolateral. It is less. So these are muscle markers, inflammatory markers. So this was published in 2011. CK difference and all these things. Now the functional outcome, randomized study shows that the functional outcome is better at 6 weeks, 6 months. However, it is same at the end of 1 year. There is no basically cohort on these studies, but a lot of prospective study trials are going on, and with some time we have all these things. But without any doubt, it is to be mentioned that the rates of dislocation is definitely less in the direct anterior approaches. And these are the literature support for doing all these things. The functional recovery, as per the literature and as per my experience, is definitely better. Usually, after I do a THR or a joint, I mobilize the patient within a 4-hour mark. The patients are less pain, having less pain with the dark. The approach is, when you go internal pain, and it is very less painful and early recovery. The functional outcome, as per literature, is good and better pain scores. Obviously, what in the West people are trying to shorten the LOS, length of stay. Average, it is 1 to 1.9 days, that is 2 days. But I keep my patient to minimum of 5 days. And the complication rate, if you don't understand the anatomy, is definitely going to be higher. So the risk of femoral injury is high. You should see it and take it from there. The cost effectiveness has not been yet calculated, but at the end of the day, what I feel that the patient is to my own together, there is no dislocation rate, it is less invasive. Obese patients, it is definitely easier, less chances of bleeding, and the support is there, and table-less. That is, if you are using a table, you need a special table, but if you are using the simple table, it is table-less, better resistance of stability, you can assess the CR on table, limb length is never an issue, better ability to equalize the limb length, and you don't need special X-rays and people. So,
these are some cases which we have done, and what I feel that it should be tried. It's not a new approach. It has been started way back in 1881, and basically limb length can be ascertained very easily. So this was with John Van Den Overschelde when I was in Belgium for learning direct anterior approach. So even at this stage, I visit places what I need to learn. Specific teaching is there, and I was there with him for 3 weeks, learned that, and then came back to India. But with whatever we do, whatever is the most important thing is the teamwork. After everything, the most important thing is teamwork. Sit with your team, learn your approaches, see your approaches, and take it from there. Any questions, please? Thank you.
Questions?
Dr. Sujit Tripathi, templating and pre-operative planning will be stopped. And please stick to the time. Time is 10 minutes. Thank you.
Thank you, organizers, for inviting me. Thank you, John, sir, Arvind, for such a wonderful gathering here. So my talk is on templating and patient preparation for THR. So there is a saying that those who sweat more in peace bleed less in war, and that I think that all surgeons should follow this particular principle. If you plan properly in your pre-operative period, probably you will bleed less in your surgery. That means you will not end up with some form of complication. And see what is the success rate of THR. If you see the last 2 decades, it has been mentioned as the most successful surgery in that is, if you consider all the fields after the cataract surgery probably. So if you see the survivorship at 90% at 20 years, the survivorship is 78%. So what you need for a successful procedure? You need 3 steps. One is proper pre-operative planning, execution, and the last part is the rehabilitation follow-up. And if you follow these 3 steps properly, probably your patient will be happy. So this is what I have mentioned. I always follow that these 6 steps should be followed by every surgeon whenever select proper patient selection. That means whether you are inside the indication or outside it. History and proper examination, investigation including X-rays, fitness in the pre-assessment clinic, appropriate implants and templating. And we have already discussed the motto of all this planning is just to restore the center of hip rotation, to equalize the leg length, to maintain the soft tissue tension, and to prevent dislocation. So coming to the history and examination, first of all, you should know that whether the hip is painful or it is because of the radicular pain from the spine. And if there is any doubt, suppose your hip is not looking so much arthritic, but it is more active in radiographic changes, probably it will evaluate for the spine. Look for the ligament discrepancy, Trendelberg, QC, and sometimes in certain inflammatory conditions, you will find out some problem there in the skin. So look for the skin condition as well. Look for the past medical history and numerous medications. There was a discussion going on just in the first phase, whether DMRD should be given or what should be given. So if the patient is on biological therapy, probably you need to stop there. Then look for the previous surgery, as Arvind has shown in my case where it was operated and he ended up with a lot of problems there during the time of surgery because of the scarring. And look for BMI also. So this is what we need to do whenever you suspect that probably you are suspecting some other pathology, we should go for MRI and X-ray of the spine. And what to do when there is involvement both hip and knee. Probably better to go for the hip, but there are certain occasions I have done the knee first followed by the hip. So that all depends on the pathology and understanding and the deformity. Coming to which lab tests are necessary, these are a huge list of tests that one should do. But what is important that we must do the CBC, your anticoagulation profile, the coagulation profile. If the patient is diabetic, you should go for hemoglobin A1C, ECG, MRSA nasal culture, and vitamin D3 level estimation for Indian patients the must. And this is what the cutoff value basically what we should take. Hemoglobin should be more than 12, HbA1c less than 7, albumin should be more than 3.5, transferrin more than 200, albumin more than 22.5, and vitamin D3 level should be more than 30. So now there is a huge debate in the last, if you see every conference, they argue whether the patient having UTI should be operated or not. So if you suspect the patient that in UTI, symptoms of UTI are there, loose features are there, and the patient also, elderly patients or risk factors are there, probably you should evaluate properly. Go for the urine culture sensitivity and do all the things. Then once the UTI is cured, then you go for your surgery. But if the patient is having only bacteriuria without any loose features, lower urinary tract symptoms are not there, no need to wait for surgery. You can directly proceed for the surgery. And the second problem is the Staphylococcus aureus. Many people, they do that. If you go to the Western country, they usually take an nasal swab culture. And I think we should also do that. We should take a nasal swab culture. And if it found to be positive, that means the Staph aureus is isolated, it is better to treat with chlorhexidine soap wash or mupirocin 2% ointment inside the nose. And that ointment has to be applied twice for almost 7 days before surgery. So the other part is about the patient preparation. What X-ray we need? We need a proper AP view, and it should be 15-degree internally rotated. I will say where is the problem. There is a one class. It will take only one class to teach what type of X-ray should be done in a patient of totally arthroplasty. But I am just mentioning it a little bit. So the coccyx and symphysis should be at least 3 centimeters. That is an ideal X-ray. It should be in one line. Look how it looks. It should like Jagannath's eye, basically, I would say. This is what it should look when we take the X-ray in the AP view. And when it looks and cat's eye is open, it's an open view, your pelvis is posterior tilted, it's an outlet view. If it is closed, that is, if eye is closed, probably it entered in an inlet view. So look for the femoral side, lesser trochanter is not visible, that means excessively internally rotated. If it is fully visible, means grossly externally rotated. And this is what I mean to say, that you should take exactly 15-degree internal rotation. And if you take excessive external rotation or excessive internal rotation, probably we will underestimate the femoral neck length, and there may be excessive elongation if you excessively rotate it. So these are the other parameters that one should look for: bone quality, protrusio, implant, malunion, non-union, destructive anatomy. And don't forget to take full view of the femur, because see, first X-ray, if you see, there is no deformity, but if you take the second X-ray, you can see there is a malunion at the diaphragmal side. And this is what the lateral view, there may be bowing. So take a proper X-ray of the lateral view as well. Traction film, if you are doing a CTH, it is a must. You should look how much reduction you are going to achieve inside the theater, or you need this appropriate osteotomy. And CT scan or oblique views are necessary when you are dealing with acetabular fracture, congenital problem, and these are the radiographic landmarks one must mark: the intertheatral line, interistitial line, because these are needed just to measure the limb and discrepancy, and you should measure the femoral offset as well. So after doing this, you can evaluate the limb and discrepancy in both the things. The important part is look for the stem. What type of stem you are going to use, whether it is a dot type 1, 2, or 3. So there is one index called as canal flare index, where we take a parameter 2 centimeter proximal to the lesser trochanter. That's called as A. And the another point exactly at the level of isthmus. So A divided B is called as canal flare index. And if it is less than 3, probably you are taking stroke pipe conformation and it needs a cemented implant. If it is more than 4.7, it is called as serpent fluid conformation. That means it is very tight canal, so you may end up with some form of fracture. And the ideal one is between 3 to 4.7. So these are the points you need to identify while doing the templating part. You need to identify the saddle points, the lesser trochanter, greater trochanter, acetabular root, teardrop, upper foraminum. And then you should go for the acetabular side, we need only 2 parameters: the exact size of the acetabular and the second part is the center of rotation of the femur. So this is a stepwise approach. If you do the templating, first determine what magnification you are using. Second, determine the leg length difference. Third, template the cuff to identify the center of rotation. And the fourth one is template the femoral component, and the final is the final hip reduction. So this is what we do for the acetabular side. And look for the polar line, that is the medial side of your acetabular. On the inferior side is the teardrop. If you mark these 2 points and take the lateral leap of the acetabulum, that exactly defines your acetabular component. So this is what the polar line teardrop. And on the femoral side, exactly you should see how much where the medullary canal is fitting, and then you look for the femoral axis and neck shaft angle, and look for the neck resection level. So templating the femoral component, you should exactly fit the femoral canal in this, as shown in this picture, and take around 1.5 cm proximal to the lesser trochanter. And if you see the literatures, they have mentioned that if you do the templating, there is an agreement of almost 98%. That is the best, that is literature that has been mentioned up to 98%. But recently, many literature see that it is of little value because of there is robotic and navigation, all these things are coming. So then implant selection is the must, and you should see what type of bearings you are going to use: metal on poly, metal on metal, ceramic on poly, or ceramic on ceramic. But there is a talk that is after this session probably, so that's why I'm not going in detail. And if it is a young patient, probably ceramic on ceramic implant good, but otherwise ceramic on poly is best one. And the wear rate with ceramic on ceramic is probably low compared to the metal on poly. And then if you see this type of problem, that is particular when the establisher is defective, when there is a fracture, we most often choose the highly porous cup. And if you see the osteoporosis, probably in that case you should go for a cemented implant. And I have already discussed about DOT type 1, 2, and 3. So if it is a type C, probably it's better to go for a cemented implant, and if it is sample fluid, uncemented. And these are the femoral components. Two types of femoral components are either fully coated or proximal coated. If you use fully coated stem, probably there will be a shielding and there will be acid in the depth of interest. So nowadays, many people they think that it's better to go for a ML rubber and the proximal coated stem. But in certain conditions, particularly this plastic, you need some modularity. In those cases, it is better to go for a S-ROM type of where you can change your version basically. So you can use those type of implants. So this is one of the examples, basically bilateral bony ankylosis of the hip that we treated in 2016. So here we know that the joint dislocation is not possible. So we planned for in situ cut, then we identify the joint line, and then tackling of the abductor dysfunction because this patient was lying on bed for almost 5 to 10 years, and there was poor bone quality. And this is what we executed: posterior approach, in situ cut, rim gently, and we then we put one uncemented cup and stem with a large head. This was another case. There was gross protrusio. So this is what we ended. This location was difficult. There is a middle center of rotations. So we did bone graft to lateralize and implant either a highly porous uncemented cup or normal uncemented cup also. Or on the backup, we should keep one mesh or anti-protrusio cage also. So this is what we did. We lateralized the center of rotations. Then the head was used as the bone graft and uncemented cage was done. So remember one thing, that failing to plan is planning to fail. So pre-op planning is crucial for successful THR, and that is what is needed to have a fun, consistently successful outcome. Thank you for your attention.
Thank you, Dr. Tripathi.
Sujit, suppose you have calculated surplus size in 46. So what size difference you will accept in the operating? That's a very basic question.
Yeah. So it's the establisher size,
Whatever, it's femur or
for femur, we say at least one on either side for establisher, one or two.
Yeah. So message is, if you are calculated anything that is one size smaller or bigger, or in establisher size up to 2 size is smaller or bigger. More than that, then you have to think intraoperatively whether anything wrong.
Oh, I think that. Nice talk, Dr. May I invite John sir for THS and options.
Okay, so we're going to go to the stem side of the total leg replacement and start with repeating what the earlier speaker had said, that there's no doubt that the total hip replacement is the most successful operation of the 20th century with a high predictability, and it's of course restored a quality of life to immobility. And really, Sir John Chandler should be credited as being the pioneer of this surgery. He has been responsible for many firsts, including the use of bone cement. He developed a monoblock stem and a high-density polyethylene cup, which he initially started with this 22.25 millimeter head, which he felt was better in terms of volumetric wear of the polyethylene. Okay, so, and this book by him is something which all arthroplasty surgeons should read before they embark on doing arthroplasty. Now the Chandi prosthesis, this was the original Chandi prosthesis. He always used the trochanteric osteotomy. Initially, he insisted that only surgeons who were trained under him and used exactly his technique could use his implant. So if you wanted to use the Chandi implant, you had to go train under him and you had to do it exactly the way he did it. Okay, and initially the implant had this collared stem. There have been multiple sort of variations of this. He developed a flange stem, the OG cup, etc., which were improvements on the original design, and then different neck lengths and stem lengths depending on the situation. Now, Robin Ling is the other person who really did a lot in the development of the cemented stems. After seeing Chandi's work, he thought he would start doing total replacement, want to do the trochanteric osteotomy. So he started working on a prosthesis which he felt he could use with the posterior approach and without doing a trochanteric osteotomy. So the rationale for his design was to try and do it with the posterior approach. He wanted to avoid the collar in the stem. He wanted to use a double taper to help extrude the cement. The steel that he wanted to use was ductile stainless steel, and that was only available in the highly polished surface at that time. Okay, so he started with this highly polished stem. This was the original design of the stem that he started with. The idea was this, he felt was different in terms of the extrusion of cement laterally as compared to the Chandi stem, which gave it a better hold, or the cement a better hold in the bone over a period of time. Now, what they found when they analyzed their prosthesis over a period of time, that there was a limited amount of substance, which they felt was a problem of the highly polished surface. So they changed to a matte design. And the moment they changed to a matte design, they found that they were having even more and more early failures. Okay, so this was an interesting thing because the original Exeter stem with a highly polished surface and a dual taper worked on the principles of machining, where when you put weight on it, it actually subsided a little bit and had a much better hold on the cement that was surrounding it. Okay, so when they did that and found this early loosening with the matte stems, they went back to the highly polished stem and then finally developed what is still available today is the modular stem, very similar design today, where you can change the length of the neck depending on what you needed at the time, as well as the offsets of the femoral stem. Okay, so that is the present design of the Exeter stem, and this is probably the most commonly used cemented stem around the world. Okay, so and you can just see this patient. This is what it was done originally, and this is about 7 years later. You can see how there's absolutely no change. If you have a good cement mantle, you have this fixed nicely. It works on the double taper principle, and the stems worldwide probably have the highest long-term survival rates available in the various registries as of now. Then we come down to the cementless stems, and basically the cementless stem obtains initial stability via a press fit. Okay, so the idea is that initially you must have a press fit, and then you have a surface which will allow bone to ingrow onto the cementless stems to give you a long-term survival. So there are various ways these can work, and this was mentioned earlier. It could be metaphysial, it could be diaphysial, or it could be metadiaphysial fits, depending on what you need to use at what particular time. So eventually the implant is stabilized by bone growing into its porous surface, but this takes some time to occur, and you want to have initial stability, and that is by the press fit. So you prepare the femoral canal with broaching for the metaphysial region, and you have to wean the diaphysial region. Okay, so the broaching prepares the metaphysis much better, because you want to remove less cancerous bone from that area, and you need to wean the canal to adequately get a good size stem in it. Okay, so either you have a stem which is slightly larger than what you have approached or reinstilled, or you have the alternative of a line-to-line preparation of the femoral canal, but then you have to have a perfect match with a roughened surface or a rough coating on the stem surface to give an initial good fit. So this is how the basic cementless stems work. Over the midterm, the idea is that you get biologic fixation with bony ingrowth or out or on growth onto the prosthesis. Bone growth should be circumferential so that you do not have any communication between the joint space and the distal aspect of the prosthesis. And long-term results really depend on balanced stress distribution across the femur. So you need to get that over a period of time. So you need to have the right modulus of elasticity. You want to avoid stress shielding in areas so that you get resorption, so that you do not want resorption of bone over time. And titanium alloys are the ones that are most frequently used in the uncemented stems. Now you can have multiple designs and geometries to work this out. So you can have various kinds of tapers. You can have a flat taper, you can have a dual taper, you can have cylindrical stems, or the Wagner prosthesis where you have multiple flanges which then dig into the side bone to give you a good fit. So depending on the type of prosthesis you have to, and the type of situation that you have in terms of whether it's a revision or a primary, the canal side based on those concepts, you need to try and get the right fit for the right sort of stem that you're trying to do. Okay, so there's also been this attempt at these short stems where you want to try and preserve bone as much as possible, but most of these really short stems like the proxima have been a failure over a period of time. So which stem do you use at the end of it? I think the debate between cemented and cementless stems will continue to rage on. I think obviously from the crowd here, the cementless stems seems to be the one most of the people prefer, although I still use cemented stems in most of my cases. The fact is both work, both need to be done properly for them to work, and both have advantages and disadvantages, and you have to use the one that you are best at to get the best results. Thank you. Questions are later.
Yeah, I think that's Thank you, Johnson. Dr. Patna. Optimal coverage.
Very good afternoon. First of all, I would like to thank the organizers for inviting me, especially to Patna, a place. Thank you, John, sir. Thank you, Dr. Arvind, for inviting me. Respected chairpersons, the topic given to me is optimal acetabular cuff positioning in THR. Now, we all know that optimal positioning of the acetabular cuff remains a challenge to all orthopedic surgeons, especially the arthroplasty surgeons. And why it is important?
No, the tips and tricks from Dr. Mutha for the cemented THR. Dr.
I'll just wait for my presentation to come on. In the meantime, thanks everyone for inviting me over here. Thanks the members for giving me this opportunity. I think most of the job is made easy by John, sir, because he told a few interesting points about cemented hip. So I will quickly run through most of the theoretical part, and I will concentrate more on how to do good cementing technique. Because at the end of the day, I'm not here to debate whether we should do cemented hip or uncemented hip. I want to say that every young surgeon like me has to be well versed with good cementing technique, because anytime you might land up in doing an cemented hip on table, and you should be well versed with cementing techniques. Though we do most of the hips as uncemented, but you should know how to do good cementing. Yeah. It's not coming over here. Okay, thank you. I just want to ask one question to the audience. How many of you know that a well-cemented, polished, double-tapered stem subsides by 1 to 1.5 in the first year? I think Johnson has told you. If you have done a beautiful double-tapered stem, it will subside in the first 1 year by 1 to 1.5 mm, and it has to happen. I think these are mostly covered. This is the surgery of the century, that is total hip replacement. It will be great injustice on my side if I don't pay tributes to Dr. Chan Chanle. As I told you, I am not here to debate upon whether to do cemented or uncemented. I just want to tell you, highlight how to do a good cemented hip. So coming to the indications, whosoever patient is fit for doing a THR is a fit candidate for doing a cemented hip. So don't think that cemented hip is not good for young people or cemented hip is not good for good bone stock patients. Any patient you can do in cemented hips. Before going into the practical part, I think everyone should know a few couple of critical points about bone cement. Cement is basically a polymer. It sets by polymerization. So the physical and chemical properties of polymers are different from other substitutes. So it sets by polymerization. So as Sir has told, polymers have an inherent property called as creep. Creep is nothing but delayed elastic deformation. So what happens is even the well-settled cement during the first 1 year, it gives way by 1 mm, and which Sir says is absolutely desirable, because of which you will have a beautiful cone-in-cone configuration. I think everyone has eaten ice cream cones during childhood. If you just stack one cone in the other cone, and if you press it a bit more, it will be practically impossible to take it out. So cemented hip with stone cone-in-cone configuration with a bit of substance is very much desirable, and it is good for the future of the hip. And you should know what cement you are using before jumping onto it, whether it is a low viscosity cement or high viscosity cement. Make sure if you're using a cement gun, use a low viscosity cement which has more working days. And coming to which type of stem you want to put in, surprisingly, there is a classification system for cemented hips also, but what Sir has told, 90% of the worldwide cemented stems are highly polished, double tapered or triple tapered stems. That's all. For us, let us stick to that. We'll use a highly polished, double tapered, triple tapered stem for cemented hip purpose. There's nothing which debatable on the establisher side. This is a highly cross-linked polyethylene or ultra-high polyethylene. Preferred are those which have 3 to 4 mm cement spacers. So cementing technique is important because it's the single most important factor which will determine the outcome of your cemented hip. So if you do good cementing, 80% of your job is done. So I think everyone knows there are various generations of cementing techniques. The most commonly followed these days is the third generation. The third generation is where you can mix the cement with hand or preferably vacuum mixing. And I will come to those details here. So the current generation is you should thorough bone preparation, especially you should remove all the cancellous bone with a thorough pulsatile lavage. Use an distal cement restrictor, which is very much mandatory on the femoral side, because without a restrictor you can't pressurize the cement. Vacuum mixing the cement, and the cement in the femoral canal has to be applied retrogradely. You can't fill from proximal to distal. Will leave a lot of voids. We have to fill the cement from distal to proximal. So what vacuum mixing does is, everyone knows, it decreases the micro air bubbles. Right? So the more the air bubbles are crossed in the cement, the less the strength of the cement. So on the establisher side, what we need to do is, we do an after reaming, give thorough pulsatile lavage, and you need to have a bloodless field, because we know for the cement to fix onto the bone well, we want a relatively bloodless field over there. So you can request your anesthesia to have a hypotensive anesthesia, but unfortunately most of the time it doesn't happen to us. So then it came out to an interesting technique. I will show you. Yes, there's something technique called as iliac wing aspiration. So what is the UK surgeons have done is, they have put in suction aspiration into the iliac wing and continuous suction. So this will dry out the acetabulum while you're cementing the acetabular. And you want to have the cement anchorage well into the acetabulum. So what is the ideal is at least 4 to 7 mm anchorage holes, and 8 to 10 is an adequate number, so that you can have good anchorage of cement into the acetabulum. Cement has to be pressurized either in acetabulum or femur, and this can be done only with the help of a cement gun. Yeah. So coming on to the femoral side. So as Sir has told, that you should understand the concept of difference between cemented stems and uncemented stems. In cemented stems, we want the contact of the stem with the help of cement to the cortical bone, not onto the cancellous bone. So you need to use the broaches. Cemented broaches are different from the uncemented broaches. The cemented broaches remove the cancellous bone, while the uncemented broaches crush the cancellous bone. So if you are planning for a cemented hip, you have to ask the company to specifically provide you the cemented broaches, where you remove the cancellous bone. So you want to fit between the cement and the cortical bone, not the cancellous bone. So that's why after doing a broaching also, you will do a thorough pulsatile lavage. While you don't want to even suction in uncemented hip, in cemented hip, you want to do a lavage, remove as much of cancellous bone over there. And as I told you, it is mandatory to have a cement restrictor, because you don't want to spill all the cement all over to the metaphysis, distal metaphysis or diaphysis. It will be a hell of a job if you land up in removing it. So as I told you, you have to do the retrograde application of the cement. You go from distal to proximal. And there are even market, these are proximal pressurizers also. But I think if you're not having, you can do with a mop also on it. And this is a bit important, because if you should use a centralizer which is a bit hollow in the distal part. As I told you, you want your stem to subside by 1 to 2 mm. So if you use a solid centralizer which doesn't allow this one, again you're losing the purpose. So after doing all these things, you want to know how well you have done on table. So you take a post-operative X-ray and see the cement in all these zones. So on the femoral side, you have the 7 zones to see how good is your cement mantle. On the acetabulum, I think everyone knows we have the 3 zones. What is mandatory is you should have at least 2 mm of cement mantle in all these 7 bones. Ideally is between 2 to 4 mm. Anything less than 2 mm is definitely not good. And we have a classification system of having this cement mantle assessment also, where grade 4 is, we have some spots in either any of the zones where there is no cement at all, and which is not at all desired. So instead of uniform cement mantle, which is something called as the whiteout X-ray. If you're having a whiteout X-ray, that's beautiful. But the thing is, you should always be aware of overpacking the cement, and especially elderly patients, where you can have this bone cement implantation syndrome. I think most of people they have faced it while packing too much of cement. We have seen transient hypoxias in these patients. So in elderly, you have to be a bit cautious while putting too much of cement. At the end of the day, I want to always tell my juniors and my colleagues also, if you are using cement, you should be also be aware of, you should be able to tackle the removal of cement also, because sometimes you will end up in doing delayed cementing where the cement sets in and the stem has not yet gone. So you should always have the backup of cement removal implants in your armamentarium. That's all. Thank you.
Now, may I request Dr. Vikas to come with the talent center. We'll have questions after this. Both speakers have. Okay.
लेंस आ रहा है वो लेंस आ रहा
I think when you're done, may I ask the audience to put forth questions if they have one? I think now Dr. Vikas is ready.
So the law of conservation of time has been disabled. So after such a difficult lecture, I am happy to talk about simple things, and I had requested Arvind, my younger brother, to make me speak very simple things because I am not a hardcore surgeon. And with people like John sir here, who has special affinity for cemented stem, I am mostly a runaway man when it comes to hip and want to finish it early and fast, and therefore I'm not able to have the dexterity of these great people who have excellent exposure to cemented stems and do it so well. So basically, we've gone through the planning of an uncemented THR. Anatomy determines the functions and results. So we have discussed correct center of rotation, offset, leg length, component size. And of course, if you plan, you need, it can predict the need, what instruments, prosthesis, and surgical approach you are going to do. Uncemented THR actually reduces the operative time, as I said. Fewer complications, of course. If you are a reasonable surgeon, an average surgeon like me, you can have a fewer complications because the cement itself has its own mind, and you need to do your cementing well before you do the THR. And that's why probably for people who were not able to cement well, uncemented THR came into being. And that's where America is at this point in time. And the warning system is always there when you have are planning for THR. So if you template well and properly see the patient, it is always better. So what's involved in planning the pathology, what you are operating, previous surgeries, examination of leg length, and I think we have discussed everything. The X-rays, you need to see how the disease has progressed over time, if it's possible. Leg length views, which Vijay very nicely mentioned, that you should have full femur before you go ahead and do the surgery. Standing and sitting LS spine, the latest pad, and most important aspect of THR which has come out in last 10 years, spinopelvic angles, pelvic tilt, so that you know how to antivert or retrovert or do whatever to the acetabular. And templating, special investigation, sometimes 3D recon, as in case of trauma, revisions, etc. So while templating, I think we've gone through all these steps already quite substantially. The teardrop, the length from the teardrop to assess the leg length discrepancy, to find out the center of acetabular component, to find out the offset, to find out the neck cut. I will not go into the details, but these are all the things which you need to do before you do an uncemented THR. Now, uncemented socket, we have to understand some key principles. Appropriate exposure is extremely important, as Sanjeer has beautifully shown. He has already shown half of my lecture, so there is no need for me to talk, but I have to finish the formality. Careful preparation, individualized planning, and perfect alignment. Excellent implant stability is very, very important. You don't have cement to fall back on. So every time you put it in, you must put it in as if there is no screw. There is no need of any screw at all. Accurate liner insertion is important, so that sometimes you have liners with posterior lip. Sometimes you need to kind of assess which part of it is becoming slightly unstable in a very bad hip, and you can adjust those hips. Uncemented, of course, it does not matter in large head where you have 32, 38 mm, 36 mm heads, and these are hemispherical lines. Uncemented socket in practice, know your implant geometry, you should know what you are going to put in. Relationship of trial to the socket size, you have to understand that in some companies there is a press fit trial at the same size of the reaming. In some companies they say ream 2 mm less and then put in the socket. In some they say ream 1 mm less and then put in the socket. So you must know what you are putting in before you actually go ahead and do the implanting. And try to always get the press fit. Screw is not needed if you are confident of your press fit. So if your press fit is the most important part. What is stability and when to use the screw, you have to understand. If your implant is moving inside, even the screw is going to be a big disaster in these cases. So you must have adequate exposure of acetabulum, whatever approach you use. It's minimally invasive, maximally invasive, whatever you do, don't damage the muscles, at least when you are exposing the acetabulum. Do good releases, especially on the superior and the posterior side. Periphery in the medial wall, teardrop is a must, spotlight notch has to be first cleared off, as Sanjeev again showed that you have to kind of medialize before you go ahead and start reaming hemispherically. Identify the landmarks and specific concerns like alignment, osteophytes, and cysts, they need to be sorted out. So as you can see, the reaming, medialize, the reamer fully eliminate cotylite fossa without penetrating the medial wall. Develop hemispherical socket, subchondral healthy breathing bone, and consider about the depth, how much you are going to go in, antiversion, hip center, influence of femoral alignment, etc. Combined antiversion, etc. So basically what you are doing again is creating a hemisphere. Actually, acetabulum is not a hemisphere if you look at it from that point of view. And most of the time when we are doing a THR, we do not get a hemisphere. So how do you create a hemisphere is important. First, you medialize, go up to the 2 or 3 millimeter of bare bone there and create a kind of an oblongity in the acetabulum. Then you start creating a hemisphere from that point of view. And it should have a face which is looking in a right direction about 45 degrees or 40 degrees inclination. And that is where you start actually in a simplistic way aligning your acetabulum while you are reaming itself. If you are reaming and you are malaligning at that point of time, you will never be able to fit in a cup at a proper alignment. So reaming in uncemented acetabulum is extremely important. Clear the peripheral soft tissue, especially the labrum. Labrum has to go out. There is no question of this. No labrum can be left intact, especially superior, anterior, and posterior side, because that will interfere and impinge in the placement of the cup, final cup placement. And inclination, we have discussed the antiversion. Implantation, clean dry surface, screw hole orientation has to be understood, especially the top screw has to go right into the iliac bone, and the alignment guide is sometimes useful, but most of us are quite adept at putting the aligner, the socket without an aligner. Avoid soft tissue interposition, gain reasonable in initial place fit. That is the most important. Acetabulum in uncemented total hip is all about initial press fit. If you don't have it, it will not work. Check position, orientation, and final. Because it will work. Sometimes you compromise in by changing the version or by changing the inclination so that the two walls are able to grasp the acetabular cup, but that is not the right technique. Post implantation, check the depth, alignment, and coverage of the cup and remove any extra osteophyte. Be careful at this time. If you try to take out the osteophyte at this point of time, sometimes you take away the bone and that cup may become loose at some point of time and you are in trouble. As you can see, while putting in the cup, you have to first see how much tight fit it is happening and let somebody else do the hammering while you yourself hold the aligner and as the cup and the shell is going in. That is very important. You can't hold it with one hand and start hammering your cup in because it usually makes you shaky and you may have 10 degree or 5 degree of final tilt which you don't want. So please hold it well and let somebody else do the hammering. So summary, careful planning, fastidious preparation, trial to confirm the plan and trust the back surface of the acetabulum. That has to be absolutely precise. Cementless stem, 10 step, pre-op templating, exposure of femur, intra measurement of head height and offset prior to the head resection. That is a very important step. Entry point into the canal, broaching of femur, and as we can read. In the pre-op templating, you have to see the femoral head diameter, which should be measured with the caliper once you take it out, if the head is not deformed. Usually, most of our cases are deformed heads, so this comes out. Canal diameter, reach the canal if the diameter is less. You have to see whether your canal is actually going to take in the stems which you have. So there are sometimes ladies which are very, very thin and dysplastic stems are needed. Predict the size of the stem, approximate level of neck cut related to the lesser trochanter. My technique is very simple. We have evolved over a period of time. Now the robotics and etc. everything has come. Basically, one finger breadth, which measures around 1.5 centimeters, is enough from the lesser trochanter for your neck cut to start. Armchair effect is the best way to lateralize your stem, because if you cut in armchair, then you have a straight wall going in, which takes your, which makes you not go into the varus while you're putting in your stem. So approximate level of neck cut, is it a high offset? You have to find out and template the line to line canal fill and then subtract one side. Actually, you should keep this templating is more for the times when you have less inventory in hand. So one side less, one side more is what you should be aiming at. So when you take a template, you must, the basic point is that you are going to put in one of the three sizes, the templated size, one size lesser or one size more. In all probabilities, same size or one size more is going to happen. Exposure of femur, we have discussed various types of approaches. I use modified Ardenge, which is lateral position and anterior approach. Intra measurement of head height is important, offset and prior to the neck resection, you have a resection guide. Most of us don't use it anymore because we have a standard operating way. We all operate in the same way. The neck cut, again, as I said, I go for the armchair neck cut. I take two separate cuts in the neck so that the flat surface or back surface of the chair kind of helps me to take in the femur, lateralizing as much as possible into the canal. So this helps me to avoid a varus angulation when I'm putting in the stem. Entry point into the canal, as you can see, and this is what the broach does. We go as close to GT as possible, taking smoothly along the wall of the lateral, almost continuously going into the wall of the lateral margin of the bone, and starting as a canal finder with 8 millimeters and then increasing slowly to avoid varus malformation. This is very, very important in uncemented stems. 1 degree of varus will increase the offset by 1.5 millimeters. So if you increase varus by 4 degrees, it will be almost 6 to 7 millimeters of offset increase. That is going to cause a lot of trouble in your abductor, tightening, in your leg length, etc. Broaching of the femur, pre-op templating is critical. Diameter should be known beforehand. Ream the canal if it is too narrow to appropriate size. Version may be marked with cautery. And you can't change the version in cementless stem without risking a fracture. But in cemented stems, you can still manipulate by 5 to 7 degrees by broaching, etc. And you must be very, very gentle, because if you try to hammer in some stems like corail, which are notorious for creating fractures, while there are some stems which are quite adaptive, which are proximal fit stems, usually do not cause fractures. Somehow this has been seen in certain stems that incidence of fracture is higher at the level of upper part of the lesser trochanter. Crab reduction by gentle traction. It should not be too much of hankering. This is the time when the femur shaft fractures, so be very, very careful. The assistant who is the first assistant, an experienced man, should be doing this traction, and it should not be somebody who has just joined, because that is a charge given to the junior most person in the team to put traction. It should not happen. Check for adequate soft tissue tension, range of motion, impingement, etc. As you can see, you are reasonably well able to understand the alignment, the length, the combined anti-version with one simple maneuver by matching these landmarks. So, never open definitive stem unless you are completely well versed with the trial. Always check for rotational stability after the trial. Go to the next size, keep unstable. One stem in 15 is unstable after the trial. So that is 7%. Some literature take it as a 7% mark, but you can always kind of go ahead and increase the size. The stem should go down most of the way with hand. At least 2/3 of the stem should go inside with hand, and then the proximal part should be slowly tapped in. The last 5 taps is going to be really tight one. So that is the time when the fracture comes. So be very careful at that point of time. Somebody should be able to put a finger. In fact, sometimes we put in a wire preempting fracture. You can always take out the wire, but preempting a fracture, you put in a wire so that if there is a small split down the calcar, you immediately tighten the wire and the stem goes in, and you can allow weight bearing immediately. Head impaction is a simple process, not a very hard impaction, just 2 or 3 taps. The taper that kind of takes the head very easily and it gets locked. Final reduction and closure should be a gentle traction and internal rotation. Again, the chances of shaft femur fracture is there if there is an impingement of the head of the stabulum. Check the stability and leg length, closure of capsule and abductors in one layer and straightforward. This is for the modified Harding approach. Templating is essential. Appropriate neck cut is critical. Avoid various malpositioning. Check for stability, approach and try. Check for fracture and deep repair. Stability is important to impart longevity. Some cases, neck femur, reasonable results. This is what you want. No stem, no screw at all. That is how it should look. Long stem, porous stems. This long, old follow-ups, 10 years, 12 years, 11 years. Thank you.
Thank you very much, Dr. Vikas. Now, I would Dr. Mutha to be here for any questions, please. Well, questions are invited from the audience. Till that time, Dr. Sanjeer.
Dr. Mutha, a question to you. You told that you need to remove all the cancellous bone while you are doing cementing in the. So do you actually need to do that? Because there is some interdigitation which ought to occur, especially in the cementing. Because cement is like a grout and it interdigitates in the cancellous bone. So if you remove all the cancellous bone, then where is the interdigitation? And you will only have the cortical shell, and it is and the cement will be loose. So do you need to remove all the cancellous bone as you just illustrated?
But I think we should be off most of the cancellous bone, because what we sold is cement is like a grout, not like a glue. So it will grow with the micro roughness of the particle rather than the cancer.
We have seen that the surgeons, they tend to use the rasp very liberally, and they remove all the cancellous bone so that they can give a bigger size of the stem. But actually, you need to conserve some amount of cancellous bone for the interdigitation of the cement.
I think John
is there any Dr. John?
I think that you have to pass up to appropriate size, but don't go trying to remove all the cancellous bone. The impacted cancellous bone in the proximal motion really has to interdigitate the cement and give you a good fix. So you need a good mantle, you need an adequate mantle, but you don't want to be chasing all the cancellous bone. So that impacted cancellous bone in the proximal area, you need to keep it.
But do you lavage the canal before cementing?
Yeah, but that will remove the cancellous bone that's not loose. That will remove cancellous bone that is here. Dr. Kapoor.
Yes. Actually, that is the difference between both the systems, right? One you lavage the canal, in one you just don't want to even put any water into the canal, not even a percentage. So that's what the difference is. But in both cases, the lemurs are different, I believe. The first one is where, the growth is different. Because first one is taking away a large amount of bone so that there is enough porosity for the cement to go in. While the other system is where you are impacting while you are doing the. So these are two different philosophies of fixation.
Actually, the initial teaching was by Chandler, but what he's saying is absolutely right. The initial teaching by Chandler was that you need to remove all the cancerous bonds. It should be a cortical shell. That's all it should be. But I think with the time, we found that cement acts actually differently. It is not a fixation device. It is an interference device. So we need to have something to interfere the cement with. So if you have an absolutely straight, smooth, and this you can see very nicely when you are doing any nail with a cement nail, with an antibiotic cement nail. If you've got an absolutely smooth nail, and when you take it out, you actually have delamination of the cement, and you get the nail out, but the cement stays inside. So that kind of thing should not be happening. So you should have something rough, which gets the cement to stay in its place.
Right. So, yes.
When you are prescribing the statement, so the angle of the version what you have previously done, I think, while hammering, you do the same angle or you do it slightly lower, because while hammering, you may you will step because you are holding that may go somewhat approximately. So do you do that?
It has to be absolutely the same. Yes, I think it has to be absolutely the same. That is what I was saying. My message was that the surgeon knows at what angle he has put in his reamer and the trial, and the surgeon therefore should be holding the cup with both hands in the same position. And there is a liner, there are instruments to guide you when you are doing a trial reduction. At that point of time, when you are putting your trial, that is the time when you have seen your aligner and the guide, and exactly in the same position, you go ahead and put in the actual cup. Now that is where the stability is required. So therefore, what I usually do is I give the tap to somebody else and I hold it with both hands so that that angle doesn't change. Now, in case of eccentric reaming, what happens? I was trying to explain something else. In case of extreme, sometimes you get reaming, which is not really hemispherical, because the bone is very osteoporotic, the quality of bone is very weak, and you end up trying to compromise on where to, how much to ream. It may go in, it may. The osteoporotic bone, what happens is then when you are doing the osteophyte removal, kind of takes away some extra bone from the posterior or superior side. So now you are left with a shell which has slight defect of about 10% on posterior superior aspect. And in that one, you want to put in an osteoporotic bone with some deformity defect. It's never going to be hemispherical, because if you want enough coverage of the cup in a hemisphere, you will go and create a protrusion. So therefore, in that case, you have to compromise at a level where you get tight fit of at least 2 walls of more than 2/3 of the cup. More than 2/3 of the cup. The cup has to have walls on 2 sides, which are kind of encompassing. So it's like a grappling the cup inside. Therefore, that concept of 1 or 2 millimeter extra reaming in osteoporotic bone, 2 millimeters, in sclerotic bone, sometimes same size or 1 millimeter. That is the difference between various philosophies. But the whole concept is to have 70% of anterior and posterior wall intact, so that they can kind of clamp the acetabulum when you are putting it in. And sometimes there is a defect in superior part. If you have a larger defect, you tend to put in graft to create more sort of this thing. But that is not a desirable situation.
Well, secondly, circulage wire, what you always use circulage wire?
It depends on the stem. See, our experience with certain stems which were fully coated was that when you are putting in those stems, especially in, and you have to look at the patient also, a porotic patient, a thin calcar, we preempt and put in a wire while we start our approaching and we start our cement stem insertion. 30% of the time, it may crack open a little bit because of the end stage hammering of the stem. Now, if you have wire in place, you immediately tie it up when you finish off the job. They wait there immediately. There is no reason for them not to be. This wire is more, and it also prevents to some extent your extension of your fracture below. Now that is a very important part in it, and that is a judicious use of your clinical aptitude of what you think may pension, but not as a routine, not as a routine.
I have a question to Dr. Aditya. I have a very basic question. You talked very nicely about the cementing techniques and about that. I would like to know that what is the best technique to how to mix the cement and what protocol you use for mixing and vacuum. Do you use vacuum mixes?
I think the ideal mixing technique is, as you said, it's a vacuum mixing technique. But practically, even I don't use it much because I use a manual hand mixing only. But I think it's not hard fast rule. But the thing is, if you do vacuum mixing, definitely there is a significant difference in the porosity of the cement. Definitely, micro air bubbles will be far more less if you do vacuum mixing.
But John sir, I want to sort of clarify from you what do you have any reservations of doing a hand digital pressurization of your cement in femoral canal? Because Chanli's result and the result of our long-term 20-25 year follow-ups are still out, and they are saying that the digital pressurization has worked for a long time.
Yeah, so I think there's no doubt that retrograde filling and cement pressurization helps. Okay, because especially with the Chanli, with the etc. implant, you want a good cement mantle, which was not so much there in the original Chanli implant. Okay, so here you want a good 2 millimeter mantle on each side. That means a 4 millimeter mantle.
So here we are discussing the cement gun. We are not discussing the mixing of the cement.
Oh, no.
What I was again. Yeah, the question was digital and cement gun.
Yeah, so for pressurizing the cement, ideally you should use retrograde filling and pressurization. Okay, so you need a distal block and then something to pressurize it against. Whether you use vacuum mixing or not, there is still some controversy over. I think if you're looking at removing air bubbles, yes, but whether that actually makes any difference in terms of long-term outcomes, we don't know.
The point is what is the temperature of the OT that you maintain? Because in manual mixing, there's a lot of discrepancy which occurs, especially that can be countered with the vacuum mixing. Because we actually don't know when to actually cement it, because just doing a manual mixing and we tend to just gauge for ourselves and then cementing. And especially if you're doing a vacuum mixing, at least probably.
But either way, you have to make sure it's not sticking before you put it in. So that's the same whether you use vacuum mixing or not. You have to make sure the cement is cured before you put it in.
I think something regarding the temperature, more important than the OT temperature is the storage temperature. Because the company guy sometimes he brings in a hot packet from the outer temperature and it will set like anything. So before you start the surgery, make sure you put your cement in the fridge. Not in the freezer, but in the fridge. Yes, as I told you, low this first.
So Sanjeev, I think that was just a small comment on what John sir was saying. Whether actually it makes any difference with bubbles inside or without bubbles. Small bubbles, they did a very nice study with cement and measured tensile strength in vacuum mixed, as well as cement which was mixed and kept for some time so that bubbles rise to the surface. Not vacuum mixing, just bubbles rising to the surface. They found that the tensile strength was better in cement with small bubbles.
Yeah. In fact, I was coming to digital pressurization from other point of view also, because a lot of studies are there which are saying there is not much of a difference in digital. It is a perceptual issue more than a issue of, because if you have a distal canal fill and you are able to really pattern cement completely, Dr. Dholake used to do that with his finger. He had a very big thumb. So, and he never needed any, gun at that point of time. So we have had a shift, but a lot of shift has come more out of. So, and what message I'm trying to give is that a lot of us here may not have access to cement guns. So it is not a crime to do a digital pressurization. And people like John sir have experience in this for last 25, 30, 40 years who have been working with cement. They have had results of 20+ years in a cemented stem and still walking very nicely with digital.
Regarding stem cementing, sir.
I have got experience when I was using cement up to the bottom of tip of the stem. Below that, I have received 3 or 4 stem fractures. I stopped doing it, and I put cement just above the tip, and I'm happy with that.
So I don't think that has anything to do with the cement. That has to do with whether there is if you reamed it adequately or not for that particular stem. I don't think that's what anything.
I'm talking about the stem fractures, not graft. Yes, implant stem fractures. That has happened.
Never seen that happen. While,
I have seen, sir, 3 and 4 cases.
while putting it in, I've never seen it happen. I think
Not while putting, sir. In follow about 5 years, 6 years.
The quality of implants.
Right.
Same implants.
So the last question comes from you.
Yeah, yes. So I have a question to all cemented surgeons who are doing work treatment with the cemented implant. There is still a group of surgeons who believe that probably matte finished stents are better because in terms of revision, if you see, if there is an isolated establishment revision, and if you need to extract, that is, if you want to do the establishment side, even at the time of triple head removal, you will see that the cemented implant comes out because it's a double tapered or triple tapered, and it is just a 2 and 4 movement that happens inside the cement. So many people they believe that probably the matte finished implants are better in terms when you need a revision surgery, probably on the establishment side, the matte finish will not be good.
so. It's on the contrary. You can actually put that same stem back inside into the mattress. Okay. So you don't.
But with cement or without cement?
Even actually without, but if you're worried about it, add some cement. Okay. But you don't even need to because it's actually not. It doesn't matter if the prosthesis is not bonding with the cement. It's there as a taper. The machine principle, as you stand on it, it's locked into the.
Because if at all some latency or some losing happens, the speed at which it's going to fail is a lot of time. So nowadays matte finish is not.
Yeah, but people are still doing
Right.
many European countries.
You can keep on discussing later also. Any last question? Yes, please.
I have one question for both the speakers. Most of the times we have pre-decided what type of cup we are using in the particular surgery. But in a particular situation where there is a primary osteoarthritis here with lot of sclerotic bone, you ream the cup, you think that you can put the press fit cup nicely, but still there is no like bleeding bone. So you're apprehensive. And then again, if you're going for a cemented cup, you will just have to rely on the macro interlock of the cement with the holes. So how do you decide in those situations? I'll go from both sides.
Whether it is a cemented hip or uncemented hip, you can't place your cup on sclerotic bone. So you have to keep on removing till you get bleeding bone.
But you cannot remove all of the whole footwear wall.
That happens particularly.
See, I'll tell you something. I'll tell you something. Yeah.
And so what we do if we have that situation is to use a small gouge and gradually take off all that sort of very sclerotic bone and then ream again. And then you've got at least some good cancerous bone into it.
So there is a thing called ring curate. There is an instrument
which is to the gouge and just take off on the very sclerotic.
There is an instrument called ring curate available everywhere.
Yeah.
That in fact you ream when you have ream, say you have a predicted size of 52, then you ream 52. Yeah, I mean your predicted size of 54, you ream 52. And you ream 52 and you are not happy with the amount of bleeding which is there. At that time, you do use the ring curate. You use the ring curate, you curate as much as possible with your hand. You will increase by 1 or 2 millimeters. You may then go up to 54, 55 ream and then use a 56 cup. You understand? But when you are committed to doing an uncemented, you cannot use a 56 cemented at that point of time. That goes because you are going ahead and doing a large head, basically. So you are committed to doing an uncemented at that situation. In a very osteoporotic bone, you will not have that situation.
Right. Thank you.
That's what I had one last technique. I will take Dr. Sujit's question. He said matte cemented stems. Sir, if you go to the history, what has happened is when most of the UK was doing this channel stems, the French have experimented with matted cemented stents. And surprisingly, they find out that 10-year, 15-year survival rates were as equal as that of channel stents.
Yeah.
So, but the concept is totally different. Yeah. So that is, this one is force close and that one is a taper close. And in that cemented, maybe that is the transition between cemented and uncemented stents. Those stents really doesn't require this 4 mm cement mantle. You can have some voids also. That is called as the French paradox. You can go to the history.
But still people are using it in Europe.
Yeah, that's what I'm saying. The French have mastered this technique.
So they use it in a different concept than the
Yeah, yes.
Thank you very much. So friends, this has generated a lot of need, and I only would like to summarize by saying that the interface that is created in cementing is between the cement and the bone, which has rightly been said, should preferably be the cortical bone along with the compressed cancerous bone. Whereas in the cementless one, the cancerous bone has to get into the prosthetic stem. And friends, on a lighter note, I would also like to mention that Dr. John Sharan operated on his mother-in-law and it did not succeed. Thank you.
Thank you, Chairperson. It was a great interactive session. Now we are moving to the next session that will be more interactive. That is expert panel discussion. The moderator is Dr. Sanjeer Patna and the chairperson is Dr. John Mutha, Dr. Amit Rastogi, Dr. Vikas Kapoor, Dr. Sujit Tripathi, and Dr. Aditya Krishna Mutha.
Thank you, panelists. Very good afternoon again. After such an interesting session, we move on to the question and answers to the panelists. So we'll keep it very short. So as much time as you give, we can move on to the next case. Now, first case is a case of tuberculosis. Now, this is the history of the patient. 55-year-old male, non-smoker, hypertensive, type 2 diabetic. The history of tuberculosis almost 20 years back, and he had completed 1-year history taking ATP. He also had features of hypogonadism, bilateral genu-valgum, hyperlax joints. There was no history of any trauma. He complained of pain, right hip, limping, shortening of the right lower limb. On examination, there were no superficial sinuses, painful right hip with limitation of range of movement, especially adduction and external rotation, shortening of the right lower limb 1.5 inches, antalgic gait with limping. There was no distal neurovascular deficit. And these were the pre-operative X-rays of the patient. As you can see, it's almost like a mortar and pestle appearance on the right side. The head is almost completely destroyed with just a beak of head which is left. And the acetabulum looks to be quite spacious. There is limb length shortening definitely on the right side, almost 1.5 inch. So how to go about it? What are the pre-operative investigations you need to do? So starting with Dr. Sujit.
Yeah, so this patient was diabetic. History of tuberculosis was there
20 years back.
20 years back. She had received probably all the modalities of treatment of ATP. And now this actually shows the motor facial appearance to me. Basically, it's a small simple head with a acetabulum which is widened. Supero is really, I can see that, but I cannot comment about the actual posture. Probably it is circumferential widening of the sternum, what I can expect from the textbook. But I get definitely CT scan for this patient to know about the sternal status. So, and before that, reactivation of tuberculosis and all this, I need to that means exclude that. So I will go for all the inflammatory markers for that. So inflammatory markers, CT scan, these investigation I need before.
So these are the questions. Now the surgical options. Initially, all these could come into the picture: excision, arthroplasty, arthrodesis, arthroplasty, and if arthroplasty, whether cemented or uncemented, and timing of the surgery, post-TB treatment, that is a question to be answered. And post surgery, long-term follow-up, because reactivation of tuberculosis is always a concern. And so pre-operative planning is absolutely essential, as we have already pointed out. Vital step for the success, meticulous history taking and clinical workup needs to be done. And investigation, CT, MRI, is there a role of synovial, any biopsy or any aspiration of the joint? Dr. Vikas, do you need to aspirate the joint?
I have a question. Why have the patient come to you for limp or for pain?
Pain, limping, pain, instability.
She has lived with pain for 20 years.
He is a he, actually. He has hypogonadism.
Yeah.
Okay. So, infection workup, CBC is normal, ESR 40, CRP is 6.5.
There is ample literature to say that even in active tuberculosis, we are going on. So I do not see the need for doing any tuberculosis investigation at present. What I would do is when I'm operating, I would send lots of biopsies. Okay, make sure that is big. And that is the best investigation in any case.
And do you need to send the TB gold test and all these things? Not required TB gold test.
Why I asked that question was sudden resurgence of pain.
Yeah.
Low grade chronic pain with limp. Sudden resurgence of acute pain. There are several things which come to mind which tells you that this is reactivated inflammation, or is it?
Yeah, there is also no active sinuses or anything.
No, I am talking about pain as such.
Pain.
It has started recently, a lot more pain than what it was 20 years ago.
Because he has a hyperlax joint, genu valgus, multiple joints are affected. So the elderly man, like a tall guy, and he has pain in other joints also. But this was the thing which is irritating, bothering him. That is a limp and a painful limp.
So if it is not suddenly very painful, extra painful, it has been painful throughout.
Yeah.
And the CRP is consistently normal. Then why are you worried
So
about
that
it?
means the audience agrees to it that we can go for it total hip straight away. Okay. So that was done actually. As you can see, these are the intraoperative pictures, excision of the deformed beak-shaped head, the remnant head. Now you can see the shape of the head. That means it's a long-standing ailment. Cemented THR, do you prefer to do an uncemented in this case or a cemented? What would be the goal, Dr. John?
So it depends on the cup. If I can get a good uncemented cup fit, I might go for an uncemented cup.
Yeah.
I would probably go for a cemented stem anyway.
So it's the quality of the bone which will decide.
So
what
if I'm
type of
not happy with the fit, I would go for a cemented.
Or is there any role if you want to add some kind of antibiotics or some kind of rifampicin to the cement or something like that to stop the reactivation of tuberculosis? Is there any concern?
So if I use a cemented thing, we tend to mix streptomycin in it.
Yeah.
But this is not a case where we are suspecting active
It's
tuberculosis.
like opening a Pandora box. Like, for example, you go inside and suddenly see pus coming out because you don't know it could be reactivating something like that. So you have to be prepared. Yeah. So it could be a two-stage procedure. If that happens, then probably we can go for a two-stage procedure. And yeah, put a space.
You have to be sure absolutely that this is septic hip.
Yeah,
and not
because these are situations in which this has happened, that you suddenly go inside, outside is looking very cold, and suddenly you find a pus coming out.
So if you have pus coming out, you don't know whether it's secondary
infection,
biogenic infection, or it
is reactivation.
Can I have the pre-op experience?
Yeah, pre-op.
Yeah, with that sort of bone stock deficiency on the established side.
Yeah.
I would like to ask, sir, if we are planning for a cemented hip, can we look in a way of having an interaction bone grafting?
Absolutely, yes.
Yeah, because that is also the question you asked was whether you want
Cemented or
not uncemented. Go back to the post of X.
The problem here is because it is not great. You are not gonna, you need to take.
Yeah. You can put an algorithm.
It's a widened cup and
Yeah, but if you look at the post of X,
slight amount of protrusion I can see also. So some amount of bone grafting requires. Yes. So from where will you get the bone? Like
so here,
iliac crest or
here you don't have to head. You can't actually take out much bone from
can
there.
take it something from the proximal femur.
From not from the person, I will take it out from the electric actually and keep it inside. And I would also use a slightly bigger cup than what you have actually put in because you've got a very thick cement mantle there. Yeah, I think this situation actually calls out for a jumbo cup.
Yes, jumbo cup.
This is a huge.
But again, if you see the type of cementing, I think it's a good penetration of cement.
I'm not saying that cementing is not good. You take this from the cement mantle.
Yeah,
that cement mantle is about a centimeter or so thick.
So in this case, there was previous history of infection that may be tubercular or maybe septic because it's a wandering estrogen. Now patient is diabetic and having recent exacerbation of pain and other things. Is there any role of hip aspiration before going to surgery?
That was discussed earlier.
It's already pre-operative workup.
Yeah.
Needs to be done as any other.
So this hip aspiration should be done this blindly or ultrasound guided?
I think it's worth getting an ultrasound to see if there's any fluid.
If there is any effusion, then this is the patient, hypogonadism patient, and then almost like a tall guy with almost like a genuine amalgam on both sides, using a knee brace to mobilize. And this is the 3-year follow-up of that same patient, and seems to be very stable. So, but we need to follow up the patient. So, workup for infection diagnostic that has been ruled out.
So the question is, your biopsies are normal, do you give them ATT? Your biopsies don't show any active tuberculosis. Do you give them ATT or not?
No.
So I think there's recommendation in various papers that you should still give them 3 months of ATT, even if they are negative.
Yeah. So the safe period of operation post-infection and treatment, that is the Babulkar's paper, recommended arthroplasty to be done for after 10 years or more between active infection and arthroplasty. So cemented, uncemented have given unequivocal results. Confirmation by biopsy and pre-op and post-operative ATT, that's the point. Wang et al. In the journals, they have recommended 2 weeks of ATT prior to operation and subsequently if biopsy is positive, at least 12 months of ATT post-op. So 2-stage operation, if persistent low-grade infection, thorough debridement, ATT lowers the potential for reactivation and subsequently THR can be a safe procedure. So, but long-term follow-up is required. So coming to the second case, the case of ankylosing spondylitis should be.
So just one question. Considering recent cost from the work, can we give ATT even without biopsy post? If suppose your biopsy came out to be normal, even then can we give ATT? Because recently the docs say that without any signs of tuberculosis, you cannot prescribe.
So you have to be sure that he had tuberculosis the first time. Okay, so if that was a biopsy proven tuberculosis, I would still give it.
I think the condition is that you have to get a biopsy and it's not a rule. You can actually write very strong and they would actually.
But recently they are diffusing. When I have said last month,
In our hospital, we are writing.
they have revised this report and they are saying that without CPDAT positive or any biopsy or anything positive, you cannot start.
But the thing is, is different. See, what they think in terms of respiratory, they don't think in terms of operative tuberculosis. And if you've got a tuberculosis in the background, it's very difficult to get either a biopsy or to get any Lot of tests.
The question I asked you, it has changed differently. Just 1 or 2 months.
Yes, so can we move forward? The next case is 27-year-old young male, non-diabetic, non-hypertensive, non-smoker, ankylosing spondylitis. He is HIV-27 positive and has pain in the right hip since 1 year, stiffness, low back and neck, limping and difficulty in activities of daily living. Right hip fixed flexion deformity 30 degrees, and abduction 15 to 20 degrees. And external rotation of 10 degrees, apparent limb shortening right side 2 centimeters, stiffness in the neck, no distal neurovascular deficit, and no associated knee and ankle stiffness. So diagnosis criteria is out there. This is the situation on the right side. It's a fused hip. And also you can mark that the SI joints are also fused. And he also has a stiff neck. So problems of anesthesia will definitely be there if you consider general anesthesia, and even during the spinal, it could be some difficulty might be there. So these are the anticipatory problems, the X-ray of the lumbosacral spine and cervical spine, and sometimes CT scan will give you amount of bone stock, medially how much of bone you have, trabecular continuity and femoral canal diameter. All these things can add to the picture. Now planning. Now the planning is uncemented, right? Right side total hip replacement. Cemented has to be kept as a backup. Lateral decubitus position, spinal epidural anesthesia, anterolateral approach, and hip that we are. The challenges what we face here could be the anesthetic challenges. If general anesthesia, then fiber optic nasal intubation has to be there by standby. Because these patients have decreased chest expansion and tidal volume, so we need good amount of blood products. Patient positioning, will it be a problem in this case?
Not much.
Because it's a flexion deformity, almost 30 degrees. So if it is,
that is fine. The flexion is never a problem. The problem
is one side. Yeah.
And it is only on unilateral side which you are operating.
So if it is a bilateral, then it is bilateral.
So the only thing you should look at is when your AP X-ray looks more like an outlet view.
Yeah.
So there is some fixed pelvic obliquity that you need to look at. Yeah.
So that is the positioning of the patient on the table. Fortunately, there was a lateral decubitus position was possible. And intraoperative challenges. Now, in such scenario, what could be the to identify the landmarks, especially the head and all these. So I'll be very fast. Okay. So reviewing judicious use intraoperative CR. How many of you recommend intraoperative CR in such cases?
I've started using it as a routine, so it doesn't matter what day.
We are doing it in situ method.
In situ.
We don't do very exactly the established base. It's better to so it is better to be having an intraoperative fluoroscopy. The reason is inflammatory arthritis, the bone is so protein, and if we do overzealous reaming in land up.
Absolutely, removing
going off the medial.
And sometimes you can also start reaming in a wrong direction. And
so actually, if you see the ankylosing spondylosis cases, even with this what looks like totally fused hip, you will usually get some demarcation.
Yeah.
Okay, when you finally ream, you will get that shell coming off.
Yeah.
And you will be able to see that fat. You will have fat, which get, and it's important to see that before you know that you're in the good.
Yes, right. So these are the intraoperative pictures. In situ cuts were made in the neck. Because we have a talk on ankylosing spondylitis, I'm going slightly faster because we go to the next case. So this was the acetabular preparation being done. And again, you have to see whichever position, you have to see the 360 degree of the acetabulum, which is a must. And then this is the acetabular component placement and final positioning of the femoral stem going in, and confirmation that is by the CR, immediate post-operative X-ray. And this is the immediate post-operative X-ray and 3-year follow-up X-ray. And this is the patient follow-up clinical picture in 3 years. The patient is receiving adalimumab. Now, how many of the panelists would recommend giving adalimumab or any other biologics to these type of patients, ankylosing spondylitis? Do you routinely give adalimumab or infliximab or something? So this patient is
so for now, I routinely send these patients to the rheumatologist and let them decide whether they need biologicals or not. But I know a lot of orthopedic surgeons treated themselves. So
Yeah,
uh,
because a lot of physiotherapy is also required because of the other condition, chest and all. Okay, so we'll move to some dysplastic cases. Now, to introduce the subject, dysplastic hips poses a unique challenge, and out-of-box solutions are sometimes warranted, and complex femoral and acetabular anatomy makes the surgery technically challenging, and we need to have a systematic approach and algorithm and appropriate implant selection and availability of both cemented as well as uncemented implants. Modular stem options need to be there. Pre-operative planning and templating is a must. And Crow's classification, we all know about that Crow's classification. So we go to the third case, Crow type 2, 33-year-old, non-diabetic, non-smoker, pain and limping since 1 year, true shortening of 1 inch in the left lower limb, stiff hip with restricted range of motion, normal blood parameters, no childhood TB, no distal neurovascular deficit. This is the situation. The head looks like almost like a coxa vagina, and it is slightly lateralized.
so how do you say this is a dysplastic hip? Because if you look at the size of the femur, the acetabulum,
there is some subluxation.
yeah, there's subluxation, there is deformity for sure.
You can say grade 1, grade 2, but it is like a grade 2.
But you don't have the real problems that you have with.
The only radiological sign is that you have got a new medial wall.
Yeah.
And so the acetabulum is very shallow and was not very
short
formed.
about
So it's wide, but it's not deep enough.
So you would treat it as any other hip.
Yeah, not any other hip in the, yeah, more or less.
More or less, yeah. So some additional information, MRI was done to see whether there is some collection of any fluid or something. And this was the pre-operative clinical picture of the patient. Shortening of almost an inch. And this is intraoperative exposure, removal of the head, lot of osteophytes. As you can see, huge osteophytes are gathered. And it was treated with the uncemented THR using a bigger head. And this is the intraoperative CM images. And this is the post-operative, immediate post-operative picture of the patient. And this is the final 2 months follow-up of the same patient. So it is relatively benign looking.
But just
Are you happy with your inclination there?
Yeah.
You're happy with your inclination on the acetabulum?
I think so. You might say that if you can make it about 40 or 45.
Yeah, okay. It looks a little vertical, but I mean, it's
but it's a bigger head. So
yeah, and I just want to this pre-operative X-ray uses something like hypertrophic osteoarthritis.
Yeah.
So these sort of cases, I make a rule at the back of my mind doing these sort of surgeries. If it is osteoarthritis, especially sclerotic bone, you do aggressive medial reading. If it is an inflammatory arthritis, I go very slow in acetabular reading. That's a simple point.
Also, back of the mind, these type of things like Perthes, they behave because childhood in young gentlemen. So most probably it behaves like a
I would say read FPFP because it was inferior medial. In Perthes, it is superlateral. So they lower down and the head will be on the top. So that is read Perthes. But in FPFP, it is lower down. It is classical medial.
So we move on to a slightly more difficult case, 20-year-old male, bilateral hip and knee pain, 5 years duration, with a windswept deformity, antalgic, waggling gait. Spondyloepiphyseal dysplasia, young boy, short, bulky statures, platyspondyly, bilateral knee OA. Osteotomies were done almost 10 years back. This was the situation on both sides. So, bilateral situation, you need to tackle one at a time or both sides together? One at a time. And do you need to take any traction views or something like that to see how much of correction you would get? The 20-year-old boy.
Yeah, but I don't think you'll get.
And a short stature, bulky.
But nothing is going to come down when you take it.
And then he had these implants. When he came to me, he had these implants. This was almost like 10 years before. So the implants were, it's basically a congenital-like problem. So you can see the quality of the bone and second osteoarthritic changes in the knee. So surgical options, high hip center, whether one needs to go for a high hip center because it's a bilateral case. You can do a high hip center here.
So go back to the previous.
previous
Yeah, so his acetabulum head is there in the acetabulum, which is there in the right place. So I would here try to get back to the native acetabulum.
So no high hip center is a no one.
I just want to ask you out of the sir, I just want to ask you what
Do bilateral shortening. Once it's two sides, you're not going to cause a limb discussion.
Prepared to do a shortening osteotomy on one side, but intraoperatively the picture changed and it appears to be a bit mobile. So I could do all the releases and bring it down. So, and most important what we faced in this situation, you need to have the CDH stem because the smallest size CDH stem is required in this case.
This is actually because of the dysplasia, because low type dysplasia looks more like a genetic boxer.
Anyhow, this is a spondyloepiphyseal dysplasia having multiple problems throughout the body. So I don't know how to classify it.
Sir, I just want to ask one question out of the way. So can we think of pelvic supporting osteotomies in these sort of cases instead of total hips?
Facial dysplasia, bilateral, it's a problem. If you have a unilateral problem, then a pelvic support.
Spondyloepiphyseal dysplasia patients, they normally, as literature says, they survive till about 50.
Yeah.
50, 55, they survive. So if you have a good quality of life, probably these 20 years matter more for this kid. So this was the kid there. So one stage, show when stretch, capsular and muscular release, nerve stretch, that the issue is sciatic nerve stretch, length issues are there, subtrochanteric osteotomy and neck shortening, cemented, uncemented, hybrid. All these options are open once we move in. And in the first stage, we did the difficult side first, that's the left side. And we managed to bring it down to its normal hip center without an osteotomy. And but we had to sink we used a CDH stem, cemented stem, and then need to give 3 screws at least for good fixation. And then once we successfully managed this side, we were slightly more daring to go to the other side. So the other side was slightly straightforward, and the head was deformed. As you can see, this is the situation. This is almost like 2 years follow-up. Now, one can argue that we can also go for subtrochanteric osteotomy, shortening osteotomy in these type of cases. So the discussion can be on that also, that whether it would have been better to do a subtrochanteric osteotomy or what we have done is justified.
As long as you're able to get it down.
It depends on how much release you have to do to get it.
Absolutely. It was almost like global release. Yeah, and with all iosoas and every global release, so we had to do. But we were very conscious whether we can injure something like a sciatic nerve injury or something like that. So advantages of a high hip center in this plastic hip. You have good host bone coverage, no need for any structural allograft, special sockets are not needed, bone stock for the future revisions, we can keep that, and it's a simplified surgical procedure. So if you have a high, but there are downsides to it. What are the disadvantages? Now, high hip center leads to liver arms and gait changes. Now it influences the hip load and range of hip motion in the high hip center. The internal rotation and flexion decreases, and the external rotation and the extension increases. And limb length discrepancy can be a concern, but in bilateral dysplastic cases, bilateral high hip center can be acceptable. So these are the summary of the surgical options you can have in group type 1, 2, 3, and 4. So should we go to one more case or?
I think we should finish. Yeah?
Okay. Thank you. Thank you very much.
Thank you, Chairpersons and Dr. Sanjeer. Next is the expert lecture session, and the moderator is Dr. Vijay.
Everybody. I hope you have enjoyed the session so far, and I would like to invite our chairpersons for the current session, Dr. Ranjit Singh sir, Dr. Soman Chatterjee, Dr. Sujit Tripathi, and Dr. S. N. Saraso. Let us start. Yeah, I'd like to invite our first speaker, Dr. Amit Rastogi, to present the expert lecture on PHR in enclosed.
Thank you, John sir. Sir. It was very nice to be back here in Patna. This is my second visit in 2 months, and I'm very grateful to the organizing team for giving me this opportunity. I think we have discussed in depth about ankylosed hips by way of various case presentations which have been happening since morning. So I'll just give you a thing. So we are not, as orthopedic surgeons, of course, there are many causes of ankylosis, not only ankylosing spondylitis, but there are so many other causes of ankylosis. But as orthopedic surgeons, what we need to be aware of is the ankylosis fibrous or fibroosseous or completely bony osseous. These are all different kettles of fish. So you cannot just label ankylosed hip. And so importance of clinical examination. If the smallest jog of movement in a hip which was considered to be ankylosed, your job is at least half done. So these kinds of hips are actually very easy to do. So they are all fibrous hips, they all had movement, you always have a cleavage plane, you always know where you are, and you can easily convert such a bad hip into a good total hip replacement, and no issues about that. Where the problem comes in is here, ankylosing with bony fusion. And this is where you do not have much anatomical landmarks to go by. So hip involvement is in all patients with ankle, and the paradigm disease here is ankylosing spondylitis. So the hip involvement is up to 30 to 50% of patients with ankylosing spondylitis, and 90% of these patients would require have a bilateral involvement. So indications: hip pain if the patient is not got a complete diffused hip; posture, functional disability, and pain in adjacent joints like spine, contractile hip. And the risk of requiring a THA and AS is about 20 to 25% in all cases. We already talked about anesthetic perspective, especially with regard to intubation and with regard to a rigid and fixed cervical spine. These patients also have a lot of pulmonary complications such as atelectasis and pneumonia in the post-operative period, and you have to guard against that. And lumbar spine disease with stable ossified ligaments may make spinal or epidural anesthesia technically difficult. So that's for the people who are standing at the head of the patient. For us who are standing on the hip side, we have to evaluate and document spinal involvement. I think we already discussed this in quite detail. And of course, we need to get ready for us of the entire spine, preoperative standing X-ray, lateral X-ray of the pelvis to prevent a positioning error, so that you know where you what you are encountering. Preoperative templating is very useful, and of course, if the patient is using etanercept or infliximab or something like that, stop it 3 weeks prior to your surgery, and make sure that you get a count before you actually proceed. So long standing long leg lateral in AP films, THA, kyphosis correction, THA or kyphosis correction. So earlier teaching was that do the hip so that patient can stand up straight. This is no longer current. Current literature favors kyphosis correction before total hip arthroplasty. So if you've got a patient who is very kyphotic, to ask your neurosurgeon friend or your spine surgeon friend to correct his spine before you start doing this here. Recognize posterior pelvic tilt, which leads to increased anterior dislocation. Standard 15 to 20 degree antibiotic cup placement may be through hip instability. So you need to close down your cup as well as make it neutral or 0 to 10 degrees maximum for the thing. And the P here is dial. So look at the dial, make sure you know where it is, and place your cup parallel to that. So technical considerations: positioning of the patient. If you got a bilateral disease with bilateral abduction deformity, it will be very difficult to place this patient in the lateral on the lateral side, and you might have to do your surgery in supine position. Where will you do your neck cut? There is your original joint line, as per the component positioning and adequate soft tissue release. So if you've got an external rotation, and that is the most common deformity, do not do a posterior approach. Start doing your an anterolateral approach, because you cannot see the neck through a posterior approach. In such a situation, identify the neck by dissecting anterior to the gradient trochanter, sacrificing 2 to 3 millimeters of posterior articular wall, and perform an echostomy. We'll come to that in a minute. And that's how you actually need to do. Need to put 2 wires, make sure that you've got 2 lines, and these lines can be seen. John sir was saying that he uses CAMs in every patient nowadays. I don't use CAM in every total hip replacement, but I use them in every patient with ankylosing. So get your 2 lines, and this line, the B line, is the one which you make first. So that is from the superior lateral acetabulum up at 45 degrees to your interstitial line, and the C line is from the tip of the nearly the piriformis fossa up to the ischial line. So that is where you will get your 2 lines, which you will need to remove the piece of bone in between the B and C lines, and we'll come to how you do that. So that's your 2 lines. So so my tactic here is a direct lateral hardening approach, a 2-step neck osteotomy, identify the foveal tissue for original joint line, TAL and lesser trochanter for component orientation, internal rotation deformity, near neutral cuff, and increase in the kind of version, but in external rotation deformity, vice versa. Adduction, if you've got a very adapted kind of this thing, make sure your cuff is a bit closed rather than being open. Femur, you don't really need to do much about it, standard pattern. So that's this thing. Can you see? You can see masks made for both the osteotomies, and we are going to remove this thing so that we can mobilize this particular thing. And that's how you actually need to do that. So you need to remove the osteophytes first, because sometimes they are covered with so much bone that you actually don't know where your neck actually is. So make sure you expose your neck properly. And that's the osteophyte being removed. And you can put your wire and start cutting your neck. So once you have done that neck cut, you do an osteotomy, you've done both the neck cut, remove that piece of bone in the middle, so that you can get this thing. At some point of time, you might even have to recut that portion because your wire is not exactly correct. But if you look at your CM properly and put your wire according to your CM picture, then you will usually be able to get it right. So you can see both the neck cuts being done, finished. And look at the bottom right picture, and you can see that sliver of bone actually being lifted off. You can just, once you've completed neck cut, you can actually get that sliver of bone. And now you've got adequate space, and you can happily mobilize your head. So if you look at it in the CM, this is what it will look like. That wire is going. This one is not going in the right direction, but it should be going much more this thing, so that you come up somewhere here. And that's how it should be. Once you have removed your sliver of bone, the head is still here. That is, the fused head is still here. That's the trochanteric area, and you've got that much more of space. And this is now you can happily put your reamer here in with guidance from your CM, so that you know exactly where you're reading and at what angle you are reading. How do you identify the location of the original joint line? I think John sir already discussed this when we were sitting here in the previous session. So foveal soft tissue and incomplete ossifying cartilage usually remain at the original joint line, and you can identify that during testing. Intraoperative radiographs also can be helpful. And if you look at this carefully, so look at this, can you see that that's the 360 exposure? You'll see the cup very nicely. That has, oh, I don't know. Okay. So that's the white thing which is starting to appear. If you go deeper, you see that this white thing actually becomes a bit larger and completely large, and then you can actually see your foveal thing. I think I have a video somewhere. Yeah. So if you look at this, ये नहीं देखने का है, अभी 2 मिनट में आ जाएगा. So once you look at it, then you will be able to find that actually the foveal is always there, and you can actually move it around in the so can you see that? So if you look at the cava is actually teasing the foveal soft tissue. And that is where you know that you have reached the medial edge of your head and you shouldn't dream any further. And to confirm that, just take a simple gesture so that you know that you've got your cup in the right place. So that's after all the reading has been done. And you can put your cup there. I think lots of people have shown cups. I don't need to go through this video. But the important thing is what Dr. Vikas was saying, that you need to have good initial press fit. And here you can easily get, if you've done everything right, you will get a very nice press fit. You wouldn't require any screws at all. And once you've done that, you can actually move around with this thing and you can see that your pelvis is actually moving around with the cup. You don't need to do anything else further. So the video is amateurish because one of my residents was taking it is not absolutely confident. So of coming close to the table. So you can see it, cup is not moving. So pelvic obliquity malposition as scapular component after often results in anterior dislocation. AS patients with a fixed kyphotic spine tend to hyperextend their legs in an attempt to look forward. In this hyperextension, we bend the cup to a more open position than exaggerated antibody. So for every 20 degrees of sagittal pelvic malrotation, after 20 degrees, every 10 degrees, you need to de-antivert your cup by about 5 degrees and I'm taking more than 55 degrees. So according to these researchers, for every 10 degrees of sagittal pelvic malrotation, above 20 degrees, the cup position should be modified so that it's 5 degrees less inclined and less antiverted. And look at your transverse scapular segment. That's your best trend here, actually. Abduction, adduction deformities. If you are in the habit of actually looking at the floor and checking it for 40 degrees, then you will end up having this kind of problem. If you are this thing, so don't look that. So if you've got a pelvis which is tilted cephalad, and the contralateral limb is fixed in abducted position, you will have, and if you want to put it at 40 degrees reference to the ground, then you are actually putting it in much more horizontal position and that desired. And if you've got an adduction deformity, then you will put it far more open. Must do adequate soft tissue releases by tenotomy, iliopsoas muscle release, and anterior-capsulotomy. Do not forcibly correct a flexion contracture without adequate soft tissue release because you will fracture the spine in a patient with hip stiff and full extension, glute maximus contractures are often present, and you might need to require to release them. There are lots of complications. So heterotopic oscillation probably is one of the most common anterior dislocation hip, susceptibility to spine fracture, cardiac palsy, intraoperative fractures, the level of calcium femoral, intraoperative trochanteric fractures, and this is one case where we use the claw and this thing to fix it. Aseptic loosening remains the reason for revision surgery, and aseptic loosening rates are as in normal population, so it's not normal. So HO, of course, this thing, I don't know how many of you use the radiation. I don't, I just use simple NSAIDs. But the interesting thing is this, no difference in studies between indomethacin, diclofenac, and naproxen. So we are all being conditioned to use indomethacin, but I don't think that actually matters with some study of usage. And this is radiotherapy. I have no personal experience with it. Sharan palsy has been reported as being more common in ankylosing patients as compared to this thing. I have never had any cases, fortunately. Hip dislocation after THR and ankylose anterior is much more common than posterior. Hyperextension is the culprit actually here. This can lead to surgical error and predispose the process to anterior dislocation. Aseptic loosening, the rates are approximately the same between ankylosed and non-ankylosed hips. So in summary, know the type of ankylosis and its etiology, investigate for other joint involvement, plan your case very meticulously. Pay regard to component orientation, especially acetabular, trigonal rotation is unremarkable. Be aware of complications and avoid very early surgery. Thank you.
Thank you, sir. Thank you. Since we are running short of time, so please no question, please. Now I invite John sir, who will be talking on THR in produced yoga.
Okay, so I'm going to talk about total hip replacement and Procrugio stabile, and a lot has been discussed during the previous case discussions. I think basically it's the intrapelvic displacement of the acetabulum and femoral head. So basically you need to look at the ilioischial line, and if the femoral head has gone medial to it, you would call it Procrugio. You can have various causes. You can have systemic causes, secondary to rheumatoid arthritis, osteomalacia, Paget's, as well as renal osteodystrophy. We also have a primary form, which is known as the orthopelvis. And in these, tends to be bilateral, while you can have other causes such as failed arthroplasty, acetabular fractures, tuberculosis, failed total hips, and in fibrous dysplasia, where it tends to be unilateral. So Chandi has classified this in various grades, starting from 0 to mild to moderate to severe, depending on the displacement beyond the ilioischial line. So 0 to 5 would be grade 1, 5 to 6 to 15 would be grade 2, and more than 15 would be grade 3. So here's an example. This is a post-tuberculosis hip, and you can see the mild Procrugio there. It's about 5 millimeters. And here you can use either form of hip, cemented or uncemented, but it's good to use the head for impaction grafting and get the hip center right. And then hopefully this hip will go on for a long time. You can similarly, another case where there's a post-acetabular fracture. You can see there's medialization. This is all healed up by now. And here you can again use the head as impaction grafting, get the hip center out to the correct place, and then do a total hip replacement. Now, what are the problems you face in Procrugio acetabuli? You have the medial and proximal migration of the hip center, which is called shortening as well as a decreased range of motion. You have deficient medial bone stock. So when you're trying to put your acetabulum into the correct position, you might go medially. Dislocation can be a problem because the neck is impinging and there are osteophytes forming on the acetabulum, which can make dislocation difficult. So you should be prepared to cut the neck first and then dislocate the head. And you have reduced peripheral bone support in some of the severe cases. And the goal is to restore the hip center, restore limb length, build medial stock, so that you want to prevent recurrent Procrugio and future possible, and be prepared for future possible revisions. And this often involves impaction bone grafting, as I mentioned. So what implants can you use? As I mentioned, the implants you can use are various. You can use a cemented cup, you can use a cage, or you can use an uncemented cup. So just a couple of examples. This is a cemented cup. Here again, it was a post-injury, post-traumatic neck fracture, as well as an acetabular fracture, where you can see the Procrugio there. And here again, whatever remnant head is there, you can use as impaction grafting and get the center correctly aligned and fixed. You may have to use a cage in the more severe defects. So you have the various types of cages which you can get into the acetabulums, put in screws, and then cement a cup into the sort of cage. So this is one way of dealing with severe deficiencies of the acetabular wall or acetabulum, where you put in a cage and then cement a cup into the cage. And you can use an uncemented cup with impaction grafting again. It does help to be a little more of a biological fixation in these cases. And because of the sort of porous coated implants, you may hopefully get some bone ingrowth into the
cup and give you a longer term survivorship. I think in the exposure, you have to be careful of the sciatic nerve because it comes very close to the joint, whether you're going anterior or posteriorly. You have to be aware that the sciatic nerve is just behind. Always attempt a dislocation, but if you're finding it difficult, don't hesitate to cut the neck and dislocate the head. Remove the marginal osteophytes before you try the dislocation. Sometimes it's better to remove these osteophytes before you try to do a good circumcision of the circumficial sort of excision of the capsule, excise, labrum, and overhanging osteophytes. So you need to get this nicely cleared out so that you have a good access to the acetabulum. When you're reaming, make sure you're reaming mostly peripherally. I've seen cases where the ream has gone right inside and gone into the pelvis. So you really have to be careful. Remove any soft tissue within the acetabulum. Again, you need to do the trial with the uncemmented uncemmented trial cup, and then don't push it all the way in, but fill this area with bone graft. So use bone graft to fill this area and then reverse ream it. That's one way of impacting the bone graft. The other way is to just stamp on it with a round shaped head and then go on to do your definitive implant. Here it's a uncemented cup with a cemented stem. Okay, so here are a couple of more cases. Here again, you can see the protrusion on the left side where it's been converted to a hybrid total hip replacement. Another one post-acetabular fracture. Here you need to get a multi-lock cup because here you need to get multiple holes into the acetabulum to get a good and adequate fixation. And here's a third one, again, a protrusion where we use the cemented hip to bail us out with impaction bone grafting to get the hip center out to the proper position. What you need to avoid is a situation like this. And I have to regretfully announce that this is one of our own cases way back in 2002, where once we've done the hip, that's what we found in the post-op X-ray. And this can be embarrassing. You know that this hip is not going to last a long time. So you must avoid problems such as this. And this is why one of the reasons why I've started using imaging for all our hips, especially for the acetabulum. We make sure that we try to get the acetabulum in the right position. So take home, I think you need to assess these protrusion cases carefully. Take care in dislocation, ream peripherally, use impaction grafting, and in certain situations, you might require cages, allograft, or augments in some of the really severe cases, and especially in the revision with arthroplasty. Thank you.
Thank you, sir. It was a quite busy talk, but I have one question. Sure. In most of the cases, in spite of good surgery, we find lengthening of the limb. How do you deal with the lengthening?
That is to do with your planning. So if you plan properly, you should not get lengthening of the limb. Okay, so you are restoring the hip center to the correct position. You should get your limb equal to the other limb at the end of surgery. Okay, so there's no reason why you should get lengthening if you plan properly in terms of your resection. No, you need to get adequate access to the acetabulum. So you need to do whatever releases you have to do to be able to visualize the acetabulum properly.
So you said in cases of potential where peripheral support is not given to access, this state, that's an end. Nowadays, people say whether they stuff is that this case.
Yeah, you have cupcake. I've not used that cupcake sort of. So, what do you mean the combination?
The first cup,
yeah, so you can do that, but you don't need that depending on the situation. Okay, so
yeah.
Yeah, that is for pelvic.
This is not when you have medial support.
Sir, there is no median.
Peripheral support is standard cases.
In protrusion, your anterior column and posterior column are intact.
Yeah.
The pelvis is not getting separate.
So I'm not saying that the pelvis is separate. It's not that. You have to have peripheral support. because the median is deficient. If somehow peripheral support is also bad.
So what you need to do is to get adequate ring capture.
Yeah. So I mean,
Because you take a case. That's why I.
no, but for this, you may have to use
That you don't get all.
Cage you can use. No, cage you can use if you've got a very big protrusion with very big wall.
You can sometimes.
You can sometimes use a cage. But the cup cage construct specifically is meant for something which is got pelvic dissociation. Posterior column being involved, anterior column being involved.
In some critical situation, you usually don't need cage all.
No, most protrusive cases will not, will not require.
Yeah, that's only in certain situations where
But in some situations where you don't have only medium language, medium deficiency, you have got some superior deficiency also. What can that means what will be?
So that's what I showed. So it depends. If you use impaction grafting, you can also deal with some of the superior deficiency. But if it's extensive, then you either have to have access to allograft, or you use augments, or you use a cage.
When you use allograft or augment, you use cementless cup or cemented cups.
It depends. No? That's not related to whether you're using augments or not. Okay? And if you're using a cage, usually cement a cup into the cage.
What my perception is, if you medial wall is deficient and you doing impact grafting, then the specific cup, non-cemented cup is better. But if there is superior deficiency also, in that case, will that graft will hold properly, because when you are
It will definitely hold.
Yeah.
It will. Why should it not?
in that condition, you can.
The only thing when you are doing a cemented cup, like sir has said, when you are doing a cemented cup and you have already done it, but make sure your cement does not flow into the.
No.
Yeah, you should. If you have a defect, you need to put something.
Superior deficiency also.
So you need.
In that condition,
You already have part of the head left behind. Use that as a block answer.
Yeah.
No graph.
In that condition, can be cementless cup.
You can always do
that.
Why not?
That is irrespective of what. So into a cage, you have to cement it up. Okay, that's a different situation.
The only problem that I face usually in profusion is trochanteric avulsion in some of the cases. Because you are lateralizing the hip center, and if it's unilateral, probably in those cases, if inflammatory conditions, I have seen few trochanteric avulsion. So how do
you just have to be careful when you're weaning the femur, because and also initially in the dislocation. Okay, so that's when if you use force, you're going to end up with avulsion of trochanter or crack into the trochanter. So especially in
I usually notice during the time of reduction, when you have put the bone graft on the medial side, superior side, you lateralize the hip center, put an uncemented cup, and then you are reducing your hip joint. At that time, actually, your trochanter is also lateralized. So I have actually came across such a problem in one of the cases. So because you are lateralizing the trochanter and the central field.
True, but the only good scenario, the classical scenario for this is a rheumatoid pregnant.
Yeah.
So with a protrusion. Now here you should not be doing all that. You should, if you are getting a problem by doing your final reduction, that means you have not done your trial problem. Trial is probably certain and not analyzing both. Yeah, and you are not
it draws the severe supromedial migration. It is not only the medial migration.
Yeah.
When actually your trochanter is averting the idea.
Yeah.
So those conditions.
I think what you need to do is do adequate releases so that you can get it down. Okay. So do that before you try your reduction. Okay, so that's what's important.
And the limiting factor here is not the adductor.
Having said that, it's not that you will never get any fracture, but it should not happen most of the situations.
Most of us don't look at IOS first.
It is an avulsion and deal with the avulsion. Yeah, you fix it.
And you have to make sure you do adequate releases before you actually try your reduction. So pull it, see that it's coming down adequately before you press it.
One more thing, look at on the mesh.
Yeah, so yeah, definitely. So if you have a defect medially, so there's no bone, then definitely put a mesh and then put the graft on it. Definitely.
Prosthetic fractures, management of prosthetic fracture is a difficult. It requires a good training and a good trauma surgeon as well as arthroplasty surgeon. Dr. Mutha.
Thank you, sir. So, periprosthetic, I have nothing to disclose with this talk. So the aim of and patient those who are obese and elderly patient with fragile bone, this rheumatoid patient, all these patients having high chances of periprosthetic fracture. And of course, cementless implant is having higher incidence in comparison to the cemented one. So management of such type of fractures would start with the prevention. And prevention, first we have seen that the pre-op templating help in a very good way in selection of the sizing of the implant. At the same time, the placement of implant also, because malreduction placement leads to fracture intraoperatively very commonly, particularly if you are using the cementless implant. So any size around 1 to 2 size lesser or bigger is okay with your templating. If there is much more disparity in that, it means there is something problem. You may land up with the periprosthetic fracture. Next is the surgical exposure that we have seen already. And a special care should be given to such type of cases where the bone stock is very poor, and you should think about your whether you should cementing or you should uncemented implants should be used. Lot of people has forgotten the technique of cementing one, but in such type of cases, if you use cementless implant, definitely the chances of prosthetic fracture will be very high. So this case was managed with the cementing both on the estabulum side and the femoral side. The classification, there is intra-op classification and the post-op classification for the both. In the intra-op acetabular fracture, again, cementless having higher incidence in comparison to cemented one. And the most common mechanism is at the time of the acetabular component infection. And if there is any mild reduction in that, then there is very high chances of that. And again, if you have used size more than 2 size bigger, then again chances of this periprosthetic fracture will be high. And of course, those having poor bone stock, definitely chances is high with this fracture. This is the classification. So treatment always start with the stability of implant. If it is stable, then you should have to observe only, and at the same time, patient should avoid putting the weight bearing for at least 2 to 3 months. And if it is unstable one, then you should revise the cuff, and then you should put the maximum number of screws. At the same time, you can also do the open reduction implementation. So and also there is option of jumbo cup is there also for such type of periprosthetic fracture in the sternum intraoperative. For the femur post-op fracture, there is classification that is well-covered classification, type A around the trochanter, type B around the stem, type C distal to the stem. What consideration should be taken care when there is post-op periprosthetic fracture? Whether implant is stable or not, again, whether this fracture is located, and what is the quality of the bone. These 3 things always comes when there is a periprosthetic fracture. So again, type A divided into greater trochanter, lesser trochanter. B is divided into 3 types. B1, the fracture around the stem, but the stem is well fixed. B2 is stem is loose. In B3, when there is loose stem, along with the quality of bone is also very poor. And then C type is well below the stem. So treatment goal is the fracture union, anatomical alignment, a stable prosthesis, so that we can mobilize the patient early. At the same time, patient can return to their previous function at the same time. So if greater trochanter, if it is stable, implant is stable and it is undisplaced, only conservative treatment needed. If there is displacement, particularly if it is 2 centimeters or bigger than that, definitely there is chances of adductor dysfunction in that case. So such type of cases should be treated with either surplus wiring or Rastogi has said about this trochanteric pain. And if many a time it's associated with the osteolysis and the implant unstable. then in such type of cases, you need to revise the implant and fix the fracture at the same time. About the lesser token saying, if it is undisplaced, the conservative treatment, if it is displaced, then surplus wiring. Like in this case, greater token and lesser token both were fractured, so surplus wiring was done in this case. For the B1, then fracture is around the prosthesis and your prosthesis is stable. In such type of cases, open reduction internal fixation should be done. The only thing the plate construct should be the long enough so that it's almost complete coverage of the fracture both proximally and distally. And also focus should be placed over the fixing the proximal part of the femur. That can be done with either bicortical conventional screw in an oblique fashion or unicortical locking screw, or you can use the surplus wiring or cable thing. About the graft, it's debatable whether we can use or not. But the B2, the fracture is just around the stem, but the stem is loose in this case. But the bone quality is good. Like in this case, the stem was loose. So in treatment option is revision of the stem at the same time fixation of the fracture. That was done in this case. The stem was revised and the fracture was fixed with the surplus wiring. Many times stem is loose, bone quality is also very poor. So treatment option in such type of cases, revision of the stem with fracture fixation, or you need to do the replacement of the proximal femur at the same time. Like in this case, there was fracture and the stem was loose. There was sinking of the stem. So that how much sinking is there, that was calculated. And the stem was templated. And also the distance between the tip of the distal fragment and the center of rotation of the hip joint was also measured. So that will guide you during intra-op period how much stem you have to put inside the canal and how much stem should be left on. So all these calculations was done, and you can see the distance that was calculated there. So that much of the stem is out, and over that prophetic part was placed, and the surplus where this cable construct was applied, and this was the final picture. Many a time this structure is too bad that it's very difficult to even preserve the bone. So in such type of cases, you may need to do a replacement of the proximal femur also. And type C, that fracture is well below the prosthesis. So basically it's a simple fixation of the fracture. But again, consultation should be paid over the fixation on the proximal fragment. And so it's in this case, it was almost the complete, the femur was expanded with the help of plate. So each case must be individualized and always look for whether it's a stable implant or unstable. If it's stable, go for the open reduction, internal fixation. And if you are doing this OREF, then always use the biologically friendly technique to prevent the muscle attachment. And whenever there is poor bone stock, always a special care should be paid. Thank you.
Thank you, everyone. Our questions from the audience.
When you are using a distal fitting stem, we deal with the fracture just to the tip of the implant. When you are using a distal fitting stem, so there it is dictated by the fit and fill of the stem. And you how do you decide how much to enter into that? You are thinking that you are measuring the amount of how much pound you want to keep the stem. So there it is dictated by the fitting of the stem.
So definitely that should be done. But at the same time, that much of length you have to keep in mind so that there should not be any leg length discrepancy. Because your stem is once in, and if there is shortening, too much shortening is there or too much, this is lengthening is there. So that may lead to problem to you. So many a times, you know, this is the size. So even if you go with, as in uncemented, we all know, many a time, if it is size 10, you put 11, or if it is size required 11, you put 10, but there is no too much of problem with that. So same concept work here also. So you can go with that, but that lead in your mind should always be there. Yeah, that is very important in such type of things.
Okay, thank you again. Now, may I request Dr. Kumar Sinha to present his paper.
Vikas? Friends, till now we were talking about DHR in urban and European and American. I have to talk about real Bharat DHR. So, friends, after doing DHR or even partial help, can we allow our patient to go to Mandir, Masjid, Gurudwara, have Indian style dinner, yoga, or Indian toilet? Of course, answer is I think no. That's why whenever if we used to come talk with the DHR patient, he used to ask, sir, हमारा कुल्ला तो बदल रहा है, हम चुपके मुंह तो बैठ लेंगे ना, फालती मार के बैठ लेंगे ना, बीच में स्ट्रेस over. So, friends, are we doing justice to our patients, Indian patients? Of course, answer is no. So we have to think out the box. Allow our patient to sit in cross leg, squat, hyperextend, and hypertension. Now, question is how to do it. So, anterior anterolateral approach is good. 360-degree exposure as usual. Acetabular cup placement in 15-degree anteversion, no neutral or reversion at all. Cup inclination 45-degree or a little bit more. Use minimum 2 screws to restrict any possible gliding movement in cup. Liner with posterior superior extra coverage is good. Femoral head stem length should be according to the optimum soft tissue density. Tight repair of capsule and abductor is very good. That is must. And temptation should be used to use larger head 36 degree if it is possible. But it should be having temptation for that. Post-op protocol, partial weight bearing after 2 weeks, hip range of exercise after 3 weeks, infascial and hip abductor exercise is must. After 6 weeks, aggressive hip range movement exercise is encouraged. Full hip movement should be achieved by 3 months. Complication. Dislocation is rare because it is anterior approach. But in this case, you are seeing dislocation because this was 4th surgery in this elderly lady. Periprosthetic fracture, as usual in posterior patient. Limb is very rare. Kinetics of PHR inside body. Doubt we all are having. Early wear and tear while sweating and Buddha position. During Indian toilet, the head articulates with posterior inferior part of the liner. Since liner thickness is similar all around, where is question of more wear and tear? Where it is at the inferior part? During cross leg sitting, all the hip is 60-degree rotation, but it is in flex position. So again, there is no question of dislocation. For kinetics inside body, this is video picture. See how smoothly patient is sweating, sitting cross leg, and how smoothly this head is articulated. Is there any chance of dislocation? See, same thing. Bilaterally, same thing patient is doing. So smoothly it is playing. So some cases are there. 35 years bell, grade 4 way. See the movement. Again, 23 year female. Bony ankle stuff like that. She was 8 months post surgery. She was pregnant. See, inside pelvis there is baby. Baby is written there. See the movement. This lady. Again, bilateral OA both the female. Forty-three years female. 3 month posterior head fracture dislocation. Same thing. This 25 years female, 7 centimeters shortening. There was social issue. Her in-laws had rejected her to stay at her home because she was not able to perform any duty. So, only 2 centimeters shortening left. Stop. How is Mutha sitting? Running, sitting cross-legged. Sixteen years boy, 2 years old non-union. Produce to stabilize. Again, 3 months old fracture there. This Vakil Sahab. Just 9 months. Again, fell back. To save our reconstruction, PHR, same sitting. Again, Dadima, partially. So take yourself that, tailor the coat as per body, not as per your coat. Give what is asked, not what you are having. To accept this, keep the hip in anteversion, optimum soft tissue tensioning, and post-op follow-up. Check during surgery by flexing the hip and 30-day abduction whether your implant is stable or not. Have faith and allow the patient daily activities. This will give you and your patient both very satisfactory results. Thank you.
So, sir, what is your take-home message to give during these surgeries to allow all patients this type of?
This is not my message. Yes, I was speaking days. Our guru Takir to say, जब तक तुम मरीज को चुपका मुक्का नहीं बिठाओगे ना, तुमसे सर्जरी नहीं करें. He used to do only partially, but in that case also, hit them from चुपका मुक्का बात. वो बोलते थे कि जब इंडियन लेडी है तुम नहीं बिठाओगे, तो क्यों कराएगा तुम सर्जरी? उसको ऐसे ही छोड़ दो. That's why पहले तो बहुत लोग छोड़ देते. और क्या करते हैं? Gutters.
Now, to what precaution we should take during surgery?
Of course.
To prevent these dislocations. We are always worried that if we allow a patient to do a
cup should be more horizontal, little bit more, not 45, but little bit more. It should be little bit anti-body. That's
normally 40 degree and 15 degree, 40 degree,
40 degree
and 50 degree anti-version is the standard.
Yes.
What you
to accept this simple 5 degree more, 10 degree more like that. And then next is not
both inclination and version.
Yes, little bit. 40 degree.
40 degree.
Yeah. That is not, but 40 degree plus. I to add little bit. My intention is posterior superior cup should be little bit protruding.
Okay.
That's my.
What I want to say, really properly done PHR patient and do whatever you have.
So why we are restricted?
But
my question is why people are restricted our patient
and survive.
Yeah.
So what is your how many years of follow?
I am doing this in last 17 years. Initially, I was so much apprehensive to share my views because people say, "Arey, tum kya baat kar rahe ho yaar? Aise kaise ho sakta?" But now I am bold enough. That's what I'm saying.
Yes. How many patients have survived for how many years?
Sir, my patients, whatever patient I am getting, those patients, the same patient, those who have done 10 years, 5 years back, they are being good.
So basically, Dr. Sinha, आपको कभी ऐसा नहीं लगा कि सेप्टिक लूजनिंग होगी या डिसलोकेशन हो जाएगा
इस लोकेशन के बारे में कभी सोचे नहीं बिकॉज वन एक सेकंड लूज नहीं बिल्कुल फॉली why there should be both wear and tear body because I mean after THR superior compartment of cup is bearing weight for whole time while it's sitting same thickness of cup material is there in their compartment so why there is more and wear here.
So let's put it this way. All of us
it is
are.
just a little bit apprehension that I see.
No. I think we all have patients who, in spite of you telling them not to squat. Okay, so the problem is not the fact that they can squat or can't squat. If it's stable for some time, they probably can do it. The problem is we really don't know what happens down the road. You are saying 15 years, they're okay. But we don't have enough studies to show that if you allow them to squat, they'll still be okay 20 years down the road. So we really need to look at that.
That's why I am saying that I'm thinking out of box.
Second thing,
it's not allowed and see what is happening.
Second thing is that you're doing some of these in really young patients. And I worry about what's going to happen 20 years down the line, because we deal with some of the revision situations, which can be really quite a major challenge. So I mean, you can do it. You can get people to squat. Question is, do we really know what's happening 20 years down the line?
So in most of the cases, Ashok sir,
Three patients can squat. Why we are restricting them? Allow them to enjoy their life.
okay, Ashok sir. So in your most of the cases, what I can see all the time, it was larger head, almost either 32 or 38. That is the advancement of technology. Ashok sir. So that is the advancement technology that prevent the dislocation of the hip. I can find in 90% of the cases it was either 32 head or 38 head. So that is that is 36. So that is the bigger this head diameter, jump distance increases, head neck ratio get changed. So that's prevent the dislocation part. At the same time, your body is thinner. So that you have also kept in your mind that over the period of time, what will happen? Yes. Thank you.
Thank you, Dr. Sinha. What will be the date for talking? What will be the date for you?
Thank you so much, sir. So it was a wonderful session today. So may I request Dr. John Mukhopadhyay sir to felicitate Dr. Ranjit sir, please. May I please call Dr. Vinod Thakur sir to felicitate Dr. Soman Chatterjee sir. Yeah. So may I call Dr. Vikas sir to felicitate Dr. S.N. Saraf sir.
Oh, भैया राइट रोड थोड़ा सा भाई ए भाई
Yeah, may I please call Dr. Manoj Chaudhary sir to felicitate Dr. Sanjeer Patna.
मूवी आ जाता
Sir,
मूवी आ जाता
sir,
मेरा
please, sir.
अगली
Manoj sir, can we be on the stage?
To felicitate Dr. Abhishek Das sir. Yeah, right now. May I? Yes. May I please call upon stage Dr. Upendra Kumar, sir. Upendra Prasad to felicitate Dr. Kumar Anup. Yeah, Upendra sir, please. Yes. On the camera. Yeah. May I call Dr. Sri Vikas to felicitate Dr. Vijay Sagar. Yeah. May I please call on stage Dr. Anup Kumar sir. Yes, sir. So, yeah.
May I call upon stage Dr. A.K. Sinha, sir? And Dr. H.N. Divakar, sir, can you felicitate Dr. A.K. Sinha, sir?
May I call upon stage Dr. Soman Chatterjee, sir, to felicitate Dr. Arvind Prasad Gupta. May I call upon stage Dr. Ratnesh Singh sir, to felicitate Dr. Taneja Singh sir. May I call upon stage Dr. Bhuvan Singh sir to felicitate Dr. Manoj Chaudhary sir. May I call upon stage Dr. Amit Rastogi sir to felicitate Dr. Bhuvan Singh sir.
So,
सब ऊपर ही रहते सर तो ज्यादा सब लोग का आता सर ऊपर में रहते तो कैमरा भी हटाना पड़ेगा।
Everyone please line for the photo session.
वहाँ भी लाइव जा लाइव जा लाइट वाला दिखाइए ना हो लाइट तो कुछ लोग सर उधर सर सीधा फ्रेम बने सर पीछे कैमरा है सर लाइव चल रहा है
थोड़ा पीछे से ले लो
जल्दी करो यार हाँ सर लाइट का है ना
थैंक यू
So. Right. So for hands-on workshop on table number 1, Dr. Sujit Tripathi, Dr. Ratnesh Singh, Dr. Sasikant will be there. On table number 2, Dr. Anup Kumar, Dr. Kumar Anupam, Dr. Ashwini Gaurav will be there. On table number 3, Dr. Sudhir Kumar, Dr. Nirmal Kumar, and Dr. Ankush Gaurav will be there. Dr. N.K. Ajay will be there. And on table number 4, Dr. Aditya Krishna Mutha, Dr. Ramakant, and Dr.
May call Dr. Arvind Prasad Gupta sir to felicitate Dr. Sri Prakash sir, please.
सर पीछे आ जाइए सर साइड हो जाइए एक मिनट रुक जाइए सर एक मिनट सर
Yeah, please join for the Sorbonne workshop on right side of the podium. Is on table number 1 and 2.
After hands-on workshop, we have this banquet session also. We have entertainment along with the dinner also.
These, that's hard. Okay, yeah.
ये मोबाइल छूट गया है किसी का लास्ट सेक्शन में आई थिंक किसी ने
तुम्हारा मोबाइल नहीं ना छूटा है? नहीं तो सर आप खा क्या रहा है? क्या मिल रहा
That's the best and best.